Good afternoon. It is 1:01 p.m. on Tuesday, September 30th. Call this second meeting of the day of the Wichita County Commissioners Court to order. Just one item on the agenda today, but it's a big one. It's a workshop to discuss employee health benefits. We have already talked a lot about this in court over the last couple of months, and so I'm not going to belabor. I'm going to invite Rachel Means from Employee Benefits Consulting up. As everyone remembers, they are the proposal that the committee recommended and the court authorized negotiations to take place. And so I guess I'll invite Rachel up to introduce herself, her team, and then...
Is everybody okay? I have a very loud voice. I have three voices. If I stay right here because I'm using two computers, is it okay for me to stay?
That mic should pick up.
Okay.
Oh,
We can.
Awesome. Thank you. If not, I have a very loud tone.
Well, Mel might wanted to use that.
so Rachel, turn it over to you and let you introduce, and then we'll
Yeah.
walk through this.
Yeah, hi everybody, Rachel Means. I brought a different set of people than our last meeting with the committee. Hannah McCracken, she runs all of our clinical programs here locally, from anybody that needs a certain drug to, hey, I need a cardiac ablation. Hannah runs that team, so she's got 11 advocates that work underneath her, and we'll talk about that a little bit more. Genevieve is our project manager for the, I think y'all have met before, and the committee meeting. So we're here today to talk through, I'm a glutton for punishment, and I actually like watching Commissioner's Court. So I watched the last Commissioner's Court. Funny story, I came in for the committee meeting, and I actually brought y'all a box cutter because of the struggle you had opening the box when the bids. And then I realized I'm walking into a county courthouse with a box cutter. This is not a good situation. So you probably have a box cutter at security.
Yes, we have.
we've
It
got
was
it.
detained, and we have freed
It was
it.
very painful watching you with the scissors. I was like, he's going to cut his hand and he's going to have to go to the hospital. This is going to be bad. Risk manager hat, right? So anyways, we're here today to talk about some of the concerns that came up in the commissioners meeting, really talk through, is it best for you guys to stay put and take a 0% increase with TAC and really have some more time, or do we want to dig in and go ahead and blow through open enrollment plan designs? So I'm here to answer any questions, really kind of talk through what's in our head collectively as a team, talk through the financials. The financials came back really good. I'm very excited to talk about that. So I thought first off we could talk through plan design, if that's okay. So kind of plan design, and then we'll go through financials. I am not a big presenter. Please interrupt me. We are very guilty of using lots of acronyms, so I will try to not use acronyms, but in my world, unfortunately, that's what we live in. So on the left here on the screen, you'll see current plan design. That is really just your current plan design through TAC with the Blue Cross Blue Shield of Texas network. When we look at this as a consultant brain, consumers of healthcare aren't in it all day long like we are. And so I look at it and say, we can really simplify this, number one, for the member, because I think having an HRA where you're like, well, I effectively have a $700 deductible, but I have to file for this, and when do I have to file for it? So that was the kind of collective agreement we had going into this was, number one, how can we simplify the plan design to be better for the members that obviously is not going to put more financial exposure on the county? So what we've done is we've said on the right, this is the draft for 2026. And I will say this is a different exercise that the court has probably been through in the past, because we have a bucket of money to work with. We know what our stop loss carriers have underwritten. So we can tweak these if y'all don't like the $30 copay I'm recommending. Let's talk about it and talk through. It's like a seesaw. You can move these levers and the numbers go up and down, right? So what we've done is our plan design here locally that we already have for our two clients here that we've been building for the last 4 years have a neighborhood network, which that's a homegrown network we have built with direct to clinics in North Texas, Tacoma independent provider. I mean, all the independent providers here locally you could think of. So we have agreements with them that we call the neighborhood. I wasn't smart enough to come up with that. So everything in that neighborhood bucket is not going to have a deductible, because we want to empower our independent providers locally that through the big carriers are usually kind of getting squeezed and the reimbursement rates going down. So we like empowering them and having the member have better access for $0. So anything through that, and we'll walk through that provider list and what that looks like in a minute. So anything outside of the neighborhood. We collectively really went through it with the committee last time and talked through what can we make that's better for the employee, but it doesn't put a financial strain on the county and kind of that happy medium. So we came up with a $2,000 deductible for individual families. So when I say outside of the network, just don't think about, like if we have a member that's going to UT Southwestern in Dallas, so we have a direct line through our advocacy program to UT Southwestern, so that if somebody was going to get treatment at UT Southwestern and they still wanted to try to get the $0 benefit, they could come through our advocacy team. As long as you're engaging with our advocacy program, everything is going to be $0 to you, right? Because we have the ability to look. I know on your Blue Cross plan what the J code that's going through UT Southwestern, I know that we're reimbursing right now about $28,000 per infusion, right? I know that I can pay UT Southwestern about 8 to 10 for that infusion, right? So that's why we can do that. So I'll kind of pause there and let y'all ask questions if you have questions on just the plan design structure.
So to be clear, two tiers of networks essentially. That neighborhood, which is ones that we've got agreements with. This proposed plan design, $0 cost to our county employees
Correct.
who go see a provider that's in that network. And then if they have to, if they choose to or need to, because there's not an agreement in place, they have to go outside of that, then their max that they're out per year is $2,000.
$2,000, yeah. And we did away with right now you guys have percentage of co-insurance, which is you have to hit the deductible, then you get 20% after that, and then you have to hit the out of pocket. For me, just even my personal health care, just $2,000. Let's do away with all the percentages and having to have the member calculate and all these EOB madness. It's $2,000. That's the max that anybody with the county is going to pay out of their pocket for health care.
Okay, Robin, did you have a question?
Yeah, what about balance billing? So
Yeah.
you.
My favorite subject right
The
now.
$2,000 is gonna be the deductible individual,
And out of pocket max.
but I'm assuming there's still gonna be balance billing potentials.
So the No
for
Surprises Act did away with all of that. So
Okay.
Consolidated Appropriations Act that was signed in 2021, that did away. You cannot be balance billed out of network at all. We have to treat the facilities the same. No Surprises Act. If we get a dispute from a facility, then we are negotiating with them and we go to a process called IDR, Independent Dispute Resolution, but the member will never be billed. They can't.
Even if they don't go to someone that's not in the Cigna or the Health Smart network.
It's illegal. We can't. That's a
There
law.
was a law change?
Yeah, that's a law that you cannot, the No Surprises Act covered, which was one thing that came good out of the federal government, but you cannot get balance.
So you would pay whatever they billed.
No, we would negotiate with them because normally if you agree to pay them, let's say there's a freestanding ER in Waco, Texas, somebody has a kid going to Baylor, right? Freestanding ER is gonna say, hey, we're not in network with any facilities, we bill through ER, and we want 300% of Medicare as our out-of-network charges, whatever. So we're gonna call them immediately and say, okay, well, here's your usual and customary in your area that Blue Cross, United, Cigna, or Aetna would pay. So we'll pay you today 200% above Medicare. They're gonna take it and run. So there's never a situation where the member could be billed more. If we get to a negotiation that we can't solve, IDR, HHS, Health and Human Services runs the IDR process that you have to go through and settle. You cannot bill the member.
Okay,
I
no
don't.
matter any situation.
Our plans cannot, that is illegal for me to do.
Not you,
Yeah.
the provider.
Well, the plan is paying the provider, so.
But the provider can still bill the member.
Yeah, they can bill the member,
That's
but
what I'm
the
saying.
plan would have to
The
pay.
balance billing, I'm talking about from the provider standpoint, not from you. Has
Yeah,
nothing to do
a
with
balance bill, if it's an out-of-network facility, if it's a true ER,
Right.
legally, they cannot balance bill the member. The plan has to pay that.
you. Okay, but if it's
Yeah.
just a non-ER situation and you pay 200% of Medicare, if there's a balance that they still.
we
want
still
the money
out-of-network?
for, Do what?
Are we out-of-network?
Yes,
Okay.
you're in the out-of-network column.
So
So
give me an
they can
example
be-
of who that would fall to, because I'm like looking across our block of business and like who would be out-of-network that isn't in tier 1 or a Cigna or a Health Smart. I'm just trying to
Right,
think of
that's
what.
what I'm thinking. If
It would be in
there
Vail, Colorado, the Vail Regional
If there is
Hospital, you
anyone,
know.
though, then they would have the 2,000, but they could be balance billed.
Our plan documents
provider.
say that nobody can balance bill our members. So I would recommend put that in the plan document that no,
But you can't control the provider though.
yeah, but I can control the plan dollars and they all negotiate. So
Right, okay, well,
if it's in your plan document that a member cannot be balance billed,
the provider can still do whatever they want.
they can
if
do
they're
whatever
not
they
in
want,
network,
yeah.
so, okay.
But
So I'm just wanting to throw out there that they could have 2,000 plus balance billing if it's an out-of-network provider
Except
type thing.
they,
The law change.
except they can't, they don't have to pay that.
Yeah.
That's what I'm understanding.
By law, and I can,
So the provider doesn't have to, the provider cannot bill the member, is that what we're saying, by law?
The
So-
member doesn't have to pay.
yeah, the no surprises act, if we're talking out of network. So I have, so.
I need to look that up.
Yeah, and I'll
That's
send
not
you
my-
the language and what our plan
Yeah.
documents read, and I'll show you the IDR process, because Hannah and her team with our claims team, they actually run those negotiations with, because what's happened, especially in Texas, in Wichita Falls, you have it happening on your plan right now, big time, I found out on the claims data. So there's a freestanding ER here. And what they've done is they say, okay, we're not in any networks. We're not going to be in Blue Cross, United, Cigna, and Aetna. But per the No Surprises Act, they know that you have to pay that bill on behalf of the member because of its out-of-network true emergency, right? And obviously, they're going to code it to make it look like a true emergency. And so you're paying $6,000 a pop to this facility locally, where we would pay $1,100 or whatever it is, right, by negotiating with them. Because if they went to IDR, HHS governs that, right? There's an unbiased intermediary that we have to deal with.
So it
So-
has nothing to do with whether it's emergency or not, it's any provider, no matter what.
No, it has to be a true emergency. Yeah.
So they can be balance billed if it's not an emergency, is that what we're saying?
I don't know why they would go the emergency, like a
No, I'm not talking about
freestanding ER.
emergency room, I'm just talking about a provider in general, I'm just talking about.
So like a
any doctor-
PCP? Like,
Yeah, any doctor.
Well-
If I wanna go to a doctor that's not in network.
so, so
well,
they're in the
there's-
network.
But,
So let's talk about that. So if you have the way we handle this, so if there's usually the only people that fall in a network, chiropractors, mental health providers, but historically they don't file claims anyway. So what we do is we actually will call ahead for the member and call the doctor saying, hey, I know you don't file claims to insurance, but we will pay you $125 a visit, cash pay rate. Poof, you're in our network. Can the member come and see you?
right.
And all I say is, hi, we have money. Do you have money? And they take money. So
I'm just wanting to clarify that it's not just the 2,000, I don't think, because you could.
It is the
potentially
2,000.
Except I think that it is, because there's two sets of hoops that would have to jump through for what you're talking about to qualify. Number one, it would have to be at a provider that's not in the Cigna network, which they're out there, but
They're out
that's
there.
that's significantly cutting out a chunk of those providers. And then the second is, because of the law change, they can send a bill to the employee. The employee,
But your PCP can send you a bill for a
Right.
lab that they did that you thought was on your preventative panel. So that happens all day long already. But my thing is,
They're in the insurance network.
no, this happens all the time. So like if you go into a PCP and you're going for your preventative appointment and you pay $0, well, they happen to do a hormone panel that isn't on the ACA list through Blue.
Yes.
You're gonna get a bill for that.
Well, you're still in your network, it's gonna go to your insurance, but yes, okay.
But you know what I'm saying? Like,
Yeah.
there's all these hypotheticals you could go through, but if we design the plan document with the legal language.
It's potential,
But even still, if you paid that lab, that would go towards that 2,000 out-of-pocket max.
yes.
So
I'm
anything you're
talking about
paying is-
Anything that's for non-contracting providers is the only thing I'm concerned about.
Okay, so no, everything is $2,000 maximum in and out of network. It's 2,000 max whether you go to Africa Hospital on a vacation. If you pay $2,000 there, the way our plans are designed, anything the member comes out of pocket, in, out. I mean, if you go buy vitamins, whatever, it's $2,000.
Ambulance ride,
It's
all
$2,000. And that's the way it was underwritten with the stop loss carrier.
because in that situation, the employee comes and talks to us, and then we talk to y'all and go, at worst, the plan is on the hook for it, the county, not the member.
Well, yeah, and
But-
you have an appeals process here. Like, I'll tell you one that comes up often is we have a motor vehicle accident or a dirt bikes. People are riding around and possibly some drinking. I don't know. I live in East Texas, and so we get a motor vehicle accident, and our plan document. The language is what
Hazardous,
I can't remember.
hazardous play.
Like there's a hazard clause in there that says, and it's kind of up for debate in my opinion, that like if you're doing something like rodeoing, there's all kinds of things and they're in all plan documents, right? And this is the language we have to review. We've had 2 instances over the last 10 years where we had a motorcycle accident, possibly intoxicated, and his indemnity policy through auto or motorcycle only covered $25,000. Well, the rest of the hospital bill was like $9,000. So we had to take it to the committee, and we said, okay, technically, the determination would be it wouldn't be covered because he had blood alcohol content of this much per the hospital records, and we let the benefits committee hear the grievance. Right? There's 3 layers of appeals, and so that would be, how does the county want to have that structured? Do y'all want to have the last say? Do we want to have healthcare strategies? Our vendor have those are the things that we need to talk about. But that's the only situation that I can think of that we've come, since I've owned a TPA, that have come to light. So.
Okay.
And we're
So-
talking about very small
Well,
instances of
so
outliers.
if I go to UT Southwest and I'm gonna have a surgery procedure, say they're gonna cut something off my kidney, and they say, Mr. Watts, I see that you've not satisfied your deductible.
Mm-hmm.
Is that deductible $2,000?
Mm-hmm.
So they'll demand $2,000 payment from me at that time.
So there's a two-prong answer to this. If you email our advocacy team saying, hey, Rachel, you know what? I have an appointment in 2 weeks at XYZ doctor. Hannah and her team, if you engage us, we will call and we can pay up front for that procedure where everything is $0 to you. Remember, if you go through our advocacy model, everything is $0. But if you want to behave just like you do now with your
Everything is what did you say?
is $0. If you go through all your deductibles are waived, all your copays are waived if you go through our advocacy model. But if you just want to act like you are now and with your ID card and just use your insurance, that's going to be the same model y'all are used to, and you're going to have that deductible to hit. The goal is to not take anything away from anybody. It's more like, hey, you can behave with your ID card with the big fancy logo, but unfortunately you're going to have to pay like you always have. If you go through this route, everything is $0 to you. Does that help explain that?
Yeah, I've just,
It's a
not
new
heard of
concept.
that. Yeah, new concept.
I know, and it's
And
new to you all.
that's-
And I would entertain that if any of you wanted to call some of the other commissioners we work with or some of our customers that we've been working with for 10 years, because when we go into a new client, they're just like, this is new. How is this going to work? And it's like, but we've been doing it. We live it all day long, so it's second nature to us. But that's why we're here to answer questions and clarify.
I have a question.
Yes, ma'am.
Let's just say you have an accident and skiing. No,
Mm-hmm.
and you're out.
That's why I do not ski.
So, and you need to go through the advocacy team, but you need care right then.
Yeah.
How quickly does the team respond to what you need?
Yeah, so I'll use a real-time example on this. So, tech company Austin CEO loves to go skiing with his whole family in Banff, which is Canada, which they have socialized medicine, and they will not work with anybody U.S., right? Like, they don't, if you pulled your health insurance card out, they'll be like, okay, great, give us the money, right? So I'm assuming you would have somebody around you that could notify us. Please go directly to the ER if your hip bone is broken. I'm just going to clarify that. So what happens then is send a message, hey, we were skiing, we think she's got a broken leg, here's the facility that we're at, and immediately that moves to Hannah's team. And they're going to immediately start reaching out to the nurse that's on call, that's managing that. It would usually be the triage at the ER. And we're going to immediately start working on that. Like, hey, what's the treatment plan? If you have to have surgery, do you want to have it there, or do you want to come home and recover at home? Those are the types of things that we'll start working on the back end. But we wouldn't know if you were at the ER, because think about it, they don't have to pre-start an ER visit. We're not going to see that coming in. So if you don't engage us, you'll have your $2,000 deductible, and we'll negotiate with them. Most of the time, they would be in a network that we could use.
So we need to call you all immediately, or get somebody to call you immediately.
I would. I mean, it's only going to save your dollars, because the more we can negotiate and monitor what's happening in that ER, because we all know this. So you go through the ER, they're going to upcode, and you're going to have every single image you can imagine. You have a broken leg, and they're MRI and CT in your head, right? And so if you have an advocate there, and they know that somebody's watching over your care, I'm telling you, the tone immediately changes.
Well, and I think like Robin was asking, so it's $2,000 no matter what, but then after you get home from having your accident and you have your surgery here, then you start getting all the bills.
So you just send those to us, because that is a 100%, they're going to bill you. And most of the time they're going to have an outside billing service that you're calling, you're getting bills from everybody. All you have to do is scan them, take a picture, email the advocacy team, and just give us, I don't know, usually 3 or 4 days. But I'm not going to tell you it can be done the same day when you get a bill, and I have to deal with somebody in Indiana that is a facility in Colorado, because you know how those outsourced billing. But that's a really good question, because vacation injuries, while they are rare, they are real. But I think in that situation, that's the reason we do what we do, because I think if you're kind of like let loose to the wild and you just have an ID card and nobody's advocating for you, like you're like, I have to have that surgery now, they're telling me I have to have it now, or I can't make it home. Well, realistically, could we split it and you could make it home or recover in the comfort of your own home? I mean, I don't know, because you're
ride ever.
Yeah.
Just saying.
Yes, ma'am.
So if you go, I understand you say call the advocacy, so everything's $0. So if you have a setup with a specialist, and you see them, say Teladoc,
Mhm.
you need to let them know every time the Teladoc appointment.
No.
Because, well, they'll bill $50, well, it's not $50 if they have that, but they will bill for the Teladoc just like if you went in.
Yeah, so you only have to engage with advocacy. Let's take two scenarios. So you're on a maintenance medication that you have to go into either a special, like endocrinologist or like a mental health provider. Those are predictable. We know those are gonna happen, right? You tell us the frequency, we're working with your physician. You just have to tell us one time that you're doing that.
So like if you have infusions every month. you
Yeah,
just
so
say,
we
"I
don't,
get
every
this,"
time
and-
we don't need to know every time. It's just, hey, you know what, I get Entyvio infusions for Crohn's. Am I doing it the best side of care, number one? Should I do it at my home, have a nurse come in? Can you buy it and bill it for me? I mean, there's all these different scenarios, but once you engage the advocacy team, it's not like you have to call us every time you go to the damn doctor. Yeah, it's more of the pre-planned, I'll give you a prime example. So if we have somebody that needs a knee replacement, hip replacement, shoulder surgery, whatever, we're gonna go in and we're gonna say, okay, your physician, your surgeon recommends this. Give us a couple days, we're gonna do a bundle, anesthesia facility, surgeon, and we're gonna get a rate. And so we're doing all the behind the scenes for you. Well, that's a one-time thing, that's a pre-planned thing, right? If you're having a heart attack, please go to the ER and do not call me. And so it's really gonna be us not making you all knowledgeable of like, when do you have to call us? But we aren't here to say every time you go to the doctor or pharmacy, you better call. That is not what it is. Because if you're on a maintenance med or you have a routine infusion or a routine mental health provider, we just need to know one time. Okay.
Is your advocacy available?
We work 24/7.
Okay.
Unfortunately, our healthcare does not stop at 5 p.m. on Friday, is what I tell people. And so I actually even monitor. We have our system, our call system is called CallRail, and we monitor that. That actually will come to my cell phone if we don't have somebody after hours. Hannah and her team. Because what is it to us? Like if you text us like, hey, I got prescribed this, or the big one now is Paxlovid because COVID's come back apparently. And it's like, well, we can get Paxlovid for free through the manufacturer card. So we're like, please call us because we don't even have it hit the plan, right? So those situations, yeah. Now, if you're just calling to abuse us on a Friday night about a knee surgery 3 weeks from now, I'm kind of call you out on it. Like I'm at dinner with my family. Can we talk about this on Monday? But those are kind of like, especially with county employees, like earning our trust is very important. And we're going to have to work hard at that at first to build that trust. But it kind of falls into place that one person has a good experience and then everybody will start calling and then their aunts are calling and they're not even on the health plan. And but those are really good questions.
I do have a question about United Regional as a whole. Seeing as I guess 90% of us use them in some capacity. So for like, you know, say you need to have a surgery, but you have to schedule it, you know, in advance, because from what I've heard, United Regional's not under the umbrella. Would we have to make these appointments at like UT Southwestern or whatever?
So what we talked about earlier is the tier 1, the $0 network, is you'll have the provider list just like you have on Blue Cross right now. And we have maps and stuff, kind of however you. The other is going to fall into a network. And unfortunately, United Regional at this point, I actually was going to try to call Corey later on my way home and just see appetite for a direct agreement. That would just fall into the all others. So you still have coverage at United Regional. You're just going to pay like you always have paid. Like you have to pay right now on Blue Cross. You're going to have to pay. Does that make sense? So you can still go there. Like it's just you're going to have your normal copays and your deductible just like you do now.
The other part of this is the advocacy part, Kelsey. You have a specialist at United Regional. You absolutely, that's who you're going to.
Mm-hmm.
That's where that applies. Yeah. The other part of this is that you talk to the advocacy team. They might be able to get you just as good, if not better, of a doctor somewhere locally, somewhere out, and should give that option of it'll cost you $0 if you are willing to work with them and get that scheduled somewhere.
Yeah, so let's just use, I have 3 boys. I don't want to change my OB ever. Don't ever tell me to change it. Don't ask me to change it. I don't care if it's $0 or $500, right? If you have an OB that you love at United Regional, you're just going to use your ID card the same way you've done it in prior years, right?
So I guess that would be my next question, because I am expecting in January.
Congrats.
I guess like this is a switch that happens, you know, going into the new year. What does that look like for me since my OB is with URPG?
Are you doing, do you know if they're doing global billing right now? Are they doing like where you pay a little bit towards your deductible every time you go in? Or are they billing you under a copay?
I just pay for me.
Okay. So is the hospital gonna get your deductible for delivery?
I would assume so. 'Cause
Okay.
I would have to deliver there.
Okay,
Unless
well,
I
that's,
have to.
Well, I just didn't know, are they gonna try to collect it before the end of the year? Because most of them, they do global billing, and they'll try to collect it up front before January. Because your deductibles run 1/1 to 12/31.
Right.
And I wouldn't want you to have two deductibles.
Right, and that's what I
So
guess
why don't, we
I-
can help you pay it
Yes,
up front.
because that was my panic, was I'm about to have a baby when everything is about to
Yeah.
either change or start over.
You're gonna be like New Year's Eve trying to have a baby.
And I'm due the 21st, but.
I feel it. No, but I think there's a world in which you can actually ask the hospital, because they do take the, a lot of them do, again, that global billing where they're collecting the deductible up front via small payments. And so, and there's a world in which I'm sure everybody remembers the good old days where we had fourth quarter deductible carryover credit, where anything incurred in fourth quarter carried over to the first quarter. We could talk about what that would look like. There's ways to get around that. It's just, I can't control United Regional and how they bill. So I can absolutely offline that with you if you'd like. Yeah, because we want to make that easier on you.
Do you want to talk through, that's all the medical side, do you want to talk through the prescription drug part of the?
Oh, yeah, my favorite. So I have the blessing or a curse to be Mark Cuban's healthcare consultant. And if you've seen him anywhere, he has attacked the drug industry head on the last 3 years. And we have helped him craft that. We are his TPA and his health plan consultant for his own employees. And so the drug market I have really dug into since I started my company in 2016. And if you watch a football game, it's college football season. I'm not going to say go Aggies, but I am paying that school for my oldest son. So I have to support them right now. Every commercial that you watch is a drug commercial, and all of those drugs on those commercials are on your RX claim file. So I'll give you a couple of examples. So when I go in to look at your top 10 drugs, it's the usual suspects. It is your Ozempic on the commercial. It is your Cosentyx. It is your Stelara, Skyrizi, you name it. What's happening right now is you don't have anybody making sure the net cost of those drugs are the lowest. Because to me, if I can send you over to Harvest, which we work very closely with Samantha at Harvest, I think Hannah, they're best friends at this point. If I can call her and say, hey, we've got this drug that's running through, it's going to a Walmart or a Walgreens or CVS, can we get that drug for cheaper, and what's our pricing? Because to you, if it's free to you and you can go anywhere and pick it up and you're taking an $18,000 drug without knowing it, that's our job to source that at the lowest. So we really go in with the community pharmacies in mind, because if you know anything about what's happening in the community pharmacy space, the Medicare Part D plans and the big carriers that own their own PBMs, they have really squeezed their reimbursement. So it's very hard to stay open. So I'll give you an example, like Harvest has a boutique where they sell candles and clothes. They have to do that to supplement to pay their employees because their per script dispensing fee is pretty low. And so we go in first off and say, okay, if you go to Harvest, Trot's, Guffey's, Franklin's, here, $0, right? So you're gonna have a $0 copay for all your generics, number one, and your brands and specialty. If you come to us where we can pull those manufacturer funds down and help with your costs, they'll be $0 to you as well. But you do have to engage us. If you don't do that and you wanna go to CVS and you wanna go to Walgreens, or you wanna go to Walmart or Publix in Florida, you're gonna have your normal copays, right? And so that's the way we approach pharmacy. It's kind of the same, that you'll have your tiers of the preferred local pharmacies, but you still have access to that big pharmacy network just like you do now through Navitus, which is the logo on your ID card through tech. Any questions on that?
The plan design for those is the same. It's the same level of copay,
That's what we did, is we matched all the copays. We just added that $0 tier, because right now I think y'all have $10 lesser of language. So on generic. So if you go in and your generic is $4, but your copay is $10, you're going to pay the $4 and not the $10 in 90% of situations. So what we do is we say, okay, we know our generics through our wholesale program are, how much lower do you think that they're?
About 50 to 70% for our wholesale mail order pharmacy programs.
And so if you want to go get the generics through our contracts that Harvest and the local pharmacies use, our cost is so much cheaper, so we can give it to the members for $0. So think about like a 60-year-old man, and I have high cholesterol, blood pressure, and I take a couple of heart medications, and all generic. That's 4 maintenance drugs, say at $8 a month. So we're at $400 a year. We're taking that $400 a year and we're putting it back in the county employee's pocket, because there's no reason for us to overpay for generics, right? We spend a lot of our time on those big high cost specialty drugs that we talk about all the time. But the goal is, again, don't take the plan design away. We're not gonna make your copays higher for not doing what the plan wants. We're mirroring what you have right now. We're just adding that $0 layer. And we had something come up out of the committee, actually. A gentleman, daughter has Crohn's, and she had been kind of bounced around for Entyvio infusions, just like approved it, then not approved it. And I don't know if you know anybody that has Crohn's or digestive issues. It's a very big deal, especially for a dependent daughter. And so we talked through his scenario and what we would do for him, because the Entyvio infusions are anywhere from, I don't know, $6,800 to $9,000 a pop, depending on site of service. So what we told him is, if you come to us, we have the manufacturer program that covers about 8 of those fills. So his cost would be 0, where every year he was having to meet that deductible every year, over and over again. And so pharmacy is where we do spend a lot of time, and we talk about it a lot, because I know that y'all don't know this, but when you look at your pharmacy spend, it's about 4 times across our block of business. It's a lot higher, because I feel like not a lot of people are advocating for those higher cost drugs. So
Additionally, we want to incentivize members to take their maintenance medications, because as they're continuing to take those medications, we're gonna see their treatment stabilize, and they're less likely to be what we call a high cost claimant, someone that's gonna end up in the emergency room or the ICU because they've not taken those medications to regulate their diseases.
Okay.
I had the joke of I was going to get a car and put a big pill on top and drive drugs around, because we spend about 70% of our time on pharmaceuticals, because that's where all the money is buried in healthcare these days, you know. So happy to. Oh, and one other thing that we are big on with drugs that is going to be a little bit different. You know, historically you have an insurance company or a pharmacy benefit manager that is coming into your life, and they're going to give you a list of drugs that works for your health. Okay, we don't do that. We have open formularies where we're not gonna take a drug off and put a new drug on. We ask that you do try just the normal lower cost therapies before you go to a $20,000 drug, but that is something different, because we're not gonna come in and give your employees a list of drug that's gonna work for their health condition. I just don't believe in that. It's not my job to do that, and it's not the insurance company's job to do that. If your doctor wants to write a script that works for you, we wanna get that covered. So that is going to be a big change, because I think most people are used to, if you're on a bunch of medications, you're watching that formulary every December, like, oh no, are they going to take my drug off? So that's another way of how we approach pharmacy.
Okay, question.
Yes, ma'am.
So my sister switched insurance, and when she switched, you made me think it is, she had to start over. She has chronic health conditions. They made her start over.
Like
So
from the
she had to
bottom
start
and work
back
up.
From the bottom and work her way back up to the medicine she was taking, so that will not happen.
No, so what we do is we're going to request from Navitas or TAC an open PA file, which that is open prior authorization. So that will give us the information of who has a prior authorization that's already been approved. And if we can't get that file, we can always reach out to providers and they know what they've tried, and we can get clinical notes to justify that. But I don't really foresee any issues. Do we want to talk Ozempic, or do y'all not want to talk
Yes.
that? Okay.
Yes.
So I feel like the last 3 years of my life have been an
Well,
Ozempic.
because that cost there is more than what we pay for insurance right now.
This is so
When you say the GLP-1,
yeah. So you have a $100 copay right now on those, but you're using a manufacturer card to get it down, right? It's probably $35.
I don't know if I have a manufacturer.
Okay, so this is the same-
I've never paid that much ever for it. All I can tell you is I've never paid that much for it.
Then somebody's manipulating your plan design, and we'll talk about that. So because a $100 copay is what you have now on your plan design. Yeah. Yeah.
What is our brand cost now, 30?
50.
30 or 35?
I think you've got a preferred and then a non-preferred.
You're talking,
If
you have diabetes.
Yeah. Yeah, we're not talking for weight
If you
loss.
don't have diabetes.
Yeah, we're not talking for weight loss. Y'all don't cover any of those
Right.
for weight loss.
No, but it's not the $50 one. It's not the generic, so it's the one in between, so it's $30, I
Okay.
guess.
Okay, so how we approach the GLP-1s and GLP-2s is, again, we don't want to take anything away from anybody. So if you want the fancy click pen that is orange and red, and you want to keep paying your copay, you keep paying your copay, and you can have that $1,000 a month drug. We work with Samantha at Harvest. Hannah really worked with her to get a compound version of this drug that we give for free. So again, not taking anything away from anybody. We were just saying simply, if you are on a GLP-1 and GLP-2 and you want a $0 copay, you can go to Harvest and have the compounded version, or if you want to use the brand name, you still pay your copay like you do now. that clarify. And I will tell you, in the long run, I think the reason we're all sitting here talking about this, if you Google the cost of Ozempic and Mounjaro for weight loss, for diabetes, not weight loss, the cost is astronomical. So I'll use 20 simple employees. 20 employees on a compound cost, I don't know, $4,000 a month. 20 employees on a brand name, just add zeros. What would that be? 22,000 probably, and then rebates a couple thousand. So let's say 20,000. So $4,000 a month directly out of the county's budget. I don't care if you're fully insured on TAC or you're self-funded, it's going to catch up to you, right? You're still paying the bill. If you're fully insured, you're just getting a 12-month loan, in my opinion. So that's the reason we have these strategies in place, that if we can move people to the compound with that $0 incentive, that's going to save everybody in the long run, and it's the same active ingredient, right? But again, we don't want to take anything away from anybody.
And when you say save us in the long run, so I'm assuming the way this plan works is that the individual employee in the county pays, let's say it's $500 a month. The county pays on behalf of the employee.
Sorry, go
Correct.
ahead.
Yeah, so there's, do you want to walk through the cost document? I think this will help answer your question.
Well, so I just basically, not so much the cost or what that is going to be right this second, but I want to understand the concept. So if all employees were moved to the zero cost medications, the county employees all were collecting $500 a piece, or the county paid on their behalf, how does that benefit us as the county?
So I'll just take from a business owner's perspective, and I'll tell you how I look at it with my employees. So I hire a $50,000 a year employee, and I have a health plan, and I'm offering them $0 for a $200 a month drug. And I'm offering them $50 for a $1,000 a month drug. That $50,000 a year employee just became a $62,000 a year employee, right? So if we take that, multiply it times 20, in the long run, your plan is still going to be spending money on those very high cost drugs. So you went from $1,000 a month to $200 a month that the county is paying for that drug, right? Even if the member has a $50 copay.
Right now, the way it works is if I go and I can get a $15 deductible and I get the medication, but if they say, hey, it's not covered, it's $1,000 for your medication, I'm the one out the money, not the county. They don't reimburse anybody for.
Okay, I think we're
medication.
talking two different scenarios. So the $0 to the member, we're gonna pay the pharmacy the lower cost for the compound. So let's say the compound's $200. Member's gonna get it for $0 because they're moving from a $1,000 drug to a $200 drug, right? And if the member has to pay that copay and they want that higher name brand, they're going to charge the county for that, just like they're charging now. When they pay the $50 copay, the pharmacy's charging Navitus, which is going to TAC, right? And so I'm not understanding.
Jim, are you talking about, are you talking about the difference right now with, we're paying $10,080 per employee per year. We're just paying that out, and that's covering everything. So if it costs $20,000 or $2,000, it doesn't matter to the employee.
Not to the price of eggs in China.
Yeah, exactly.
Under this plan, we won't be writing that $10,080 check a year to an outside entity. We're going to have a small portion of it that's going to be paying for our fixed costs, our administrative side. The rest of it is just us paying ourselves to build up a claims fund so that we're paying for whatever employee costs they have that they're not paying for, which is going to be large. Where the county ends up benefiting here is, rather than $5 million a year that we're handing over to TAC and to Blue Cross Blue Shield, we are assuming the risk or the benefit of, if our employees only cost, the claims we pay out are only $3 million, that extra is what we then have to reinvest however we choose to reinvest. The risk side of that is that if we have a year of extremely high claims, we are the ones picking that up rather than the insurance carrier.
So how do we allocate for that as a county?
So there's two pieces. I'll let Rachel.
No,
talk
go
about-
ahead. This is I'm used to this.
So
Let me get a breath.
we protect ourselves with stop loss insurance. That's where we're paying an insurance company to put ceilings on each of our employees as an individual and aggregate the cost of everybody together. We say we don't want to go over.
So we call it belly buttons and blankets. Belly button deductible, because everybody has a belly button, so everybody has an individual deductible. And the blanket is like your GL, your liability policy. So you'll never go aggregate over this number, and you'll never go belly button over a certain number on a specific individual.
The county's paying a premium to stop loss insurance to insure that risk, so that if we have a terrible year and everything goes crazy, we still know what our maximum liability is. And then the county is essentially putting that money aside to make sure that we can cover up to that point if we have that terrible year. But if we don't hit that terrible year, we have just kept that money ourselves to then reinvest somewhere else rather than pay someone else to do that.
Yeah.
And this is the forum that we talk about, you know, I'm a doomsdayer. I talk about worst case scenarios. My husband and I have 400 employees. I have restaurants. We have a trucking company, my agency, and the TPA. And so I'm used to this as a cash flow mechanism. And so that's really a discussion that we had with the committee last time, was do we want to make it look and feel like your current premiums that you're paying into TAC, just the 5 tiers, same payment every month, and you just get the benefit of, you get to see your claims fund go up and down, and then it's yours at the end of the year? Or do we really want to do our weekly check registers where we're doing a self-funded model? I like the second because it's way cooler with data. I just don't know on y'all's side, that's something that the financials are going to be the same regardless, right? Our stop loss carrier has underwritten this based on your plan design and your risk, and the numbers came back great. So I'll kind of just walk through what that,
Yeah.
and then y'all just stop me. So when we say fixed fees, so we've got two buckets of fixed fees. We've got stop loss premiums, which, remember, your specific deductible is specific based on a belly button. So every single person's going to have a number on them that the county is going to pay up to that amount. On your size, across our block of business, you would actually probably be closer about a $200,000 specific, but we're being very conservative first year going in. So we quoted 100, 125, and 150,000 specific deductible. On my side, the 150,000 is definitely your sweet spot, and I'll talk through why and the premiums you're going to pay for that. So if you go on your annual stop loss premium, that is your fixed fees that you're going to pay on your admin bill every month. So you're going to pay for specific deductible, and you're going to pay for aggregate. And you'll notice your aggregate coverage is the lower amounts, $3.79, $4.40, $4.87. That is very cheap for a reason, because our underwriters that underwrite our business model and your risk, they know the odds of you hitting that maximum are super low. So that coverage is really, really cheap. I have owned my company for 10 years now. I've only had one company over 10 years, and we have 200 customers that have hit that aggregate. And it was a very small group that had a preemie baby, long story there. But it doesn't matter because they had reinsurance to cover that, and they never paid over their maximum. We don't want to hit that, just to clarify. Ag accommodation, we threw this in. It's $1.50 per employee per month. So what this says, if we get January and you've only put, I don't know, let's just say $500,000 of premium in, and we have $5 million in claims or whatever the first month, they're going to accommodate. The stop loss carrier is going to accommodate, saying you're never going to pay over that. It's just another layer of risk going in. We'll probably recommend you take that out year 2, but for year 1, we're just very, very conservative with cash flow. We don't ever want y'all to have to, accommodate for a bigger claim month. So that's just kind of us putting more reinsurance protection in there. So all in all, on the stop loss premiums for the $150,000, it's about $419,469. Okay, then go down. So on the next one, these are all the fees that are kind of, they're fixed costs, but we've got to make a couple of decisions on network. Do you want to use the big Cigna fluffy network? Do you want to use a smaller regional network? Do you want to use a Health Smart where the discounts aren't as great? But the great thing is this is the bucket money we're working with. All those little pieces, we can make a 5-minute decision. So Sage Admin, so that is the third-party administrator. So a third-party administrator, what a third-party administrator does, they handle customer service. They have the payer ID that claims are submitted to. So like on your ID card, you have Sage 1, which would be the payer ID. The providers that are taking care of your members, they're going to file a claim to our payer ID. That comes into our software. We're going to reprice the claim with our repricing tools that are in our software, and then we're going to pay the provider, right? So a TPA is the processing system, customer service, produces ID cards. So that is $24 per employee per month. That is the only money the TPA makes. I will tell you that. I sign a disclosure every year. I'm very OCD about being way too transparent because there are some very bad TPA actors out there that takes a lot of percentage of savings on out-of-network claims. I don't play any of that funny stuff, so just to get that out of the way in the public record. Cigna PPO network. This is literally a pass-through cost. So caveat here, our cost for Cigna PPO right now is $15.84. It is going up to $16 on April 1st. So I'm gonna charge $16 starting January 1st, and we'll just reconcile at the end of the year the 22 cents or whatever. Other Cigna required fees. So these are for Cigna to do any of their network claims. If a claim's going to fall to the Cigna network, they require that their case managers do the pre-cert, which is fine because the way we work with Cigna, those are only going to be things that kind of leak out of our neighborhood area. So think about that would be an MD Anderson claim in Houston or a Baptist in San Antonio. Usually it's a college kid that's living somewhere else, right? And that's just per employee per month fee. Medicare repricing, so when we do our neighborhood claim, $6.75 per employee per month. So this pays for, I have 3 different Medicare repricers that are ingested into my system because Medicare is based off of locale. So you in Wichita Falls have your own area that we have to have the tools to reprice all of our claims. So that's just a pass-through fee. Teleconsult, that is a flat $5.50 per employee month that is paid to the group of physicians that are in Childress, Texas, that they take care of our plan members. They literally deliver babies in rural clinics. I would trust them with my life. So that goes straight to the docs that take care of that 24/7 telemed. Health Hero, this is just a pass-through. This is what I pay for software for the app. So we customize the app. I know that a lot of county employees, I have gotten like, we don't want to use an app. Well, you don't have to use it if you don't want to. This is just for your convenience. So we actually tailor the app to all your different programs. So it'll have Wichita County logo. It'll have, I want to talk to an advocate, or did you get prescribed a new drug? Or hey, I need a rheumatologist. You'll have your provider. Any messaging that Sonia wants to get out, like, hey, did y'all know we were having a flu clinic or whatever, that is totally customized and we can message anything through that. So that is pass through. If you don't want the app, you don't have to pay for it. I suggest have the app because the advocacy team works in it all day long.
And it also comes with a website-based browser. So if you're not an app utilizer, there will be a website browser that you can use as well.
Yeah.
Just to
And
clarify. So I know folks don't have a smartphone. They want to get on the computer and look it up.
And why am I using it?
So this would be to pull a virtual ID card. If you want to pull up your own benefit guide and know, hey, this is my benefit plan structure. If you want to talk to an advocacy team member, you can reach us through that channel. If you want to look at what your neighborhood provider list is because you're driving and you don't have it in front of you, the piece of paper, you can access all of that on your phone or your computer.
A lot of people use it, like, especially a lot of our chronic health conditions. They go to another specialist and they're like, oh my gosh, I was just written another prescription or infusion, or they said I need this. They just messaged us on that, and the advocates are working on that because it's kind of like we train the population that if you come through our resources, we're pretty much always going to get it for $0 for you. And if we can't get it, we're going to find it because there are new treatments coming along all day long. And so it's really just to communicate with the benefits team. But again, if you don't want to do that, you can use your ID card and run out in the wild. So, do what?
I think the app is
We have really evolved this. We built it from the ground up with it's evolving a lot. I'm one of those, and I'd love somebody to argue me on this, Mark Cuban. I'm not a big AI and customer service or healthcare type of person. It would be very easy for me to hire AI agents and save a ton of money on customer service with my business. I just refuse to do it because I know when I even try to go to AT&T and order a new phone for my son at college, and I'm like, I know you're a bot. Like, just give me to a person, right? So that's why we really developed the app to streamline the communications and get it out of email setting, because people are guilty. They send us HIPAA and PHI via email all day long. And so if we could get it through the app, obviously it's better, but it's not required. That was a really...
Live chat? Is it live chat?
It goes to a type form right now, but we are working on the development. So what's in development right now is the desktop portal, which will be live by the time y'all are live because it's going to live 11/1, and then the real-time chat is in development, and we have 6-week sprints. So probably I'll commit to January 15th, probably before Christmas. But I've learned having software developers, they call them sprints, but they should be called walks because nothing happens quickly.
But I'm still having trouble. I mean, I'm thinking about going to the doctor in the last 5 years. I've never done anything like you're talking about.
Nobody
I'm not
does
using
anything
that
like we
to
do.
utilize or do
Yeah.
or perform any function for me. I go see the receptionist, check in, Mr. Watts will call you back. We do. Doctor sees me, says, hey, go to Dr. Watson over here and see him.
Sure. So
When-
Commissioner Watts, can I ask you a
When did I engage
question?
into an app?
Can I ask a question? Do you think our healthcare system is broken?
Well, I mean, it's all I know.
Yeah.
I
No, I'm
couldn't
just gonna ask
answer
you, 'cause there's
that.
a
I mean,
reason that
do
I have
think
been
I
summoned.
pay way too much for
Yeah.
medications and things like that?
So you-
Probably not for a doctor's fee, but yes,
Yeah.
for a medication more than
Yeah,
likely.
so I will tell you, you're abnormal if you haven't had a problem in the healthcare system. Because when you have a county employee that's working in road and bridge, that doesn't have time to think about his healthcare, his wife's working her job at the school district, and he has an advocate that he can say, okay, everything's taken care of, I can just go to my doctor and get my drug.
Well,
Yeah.
but hold right there. In order for you to get all that information, I, as the road and bridge employee, have to start doing something. And then you're gonna move me to a doctor.
I'm not gonna move.
I mean,
no.
I'm not understanding how I got on an app
So
and did
You
it.
can do it either way.
Yeah, you don't have to, you can use your ID card and go to your normal doctor like you
Just
always
like
do.
you always have.
That's,
So,
yeah.
Jeff, here's what I would say. You're right. This model is engaging our employees and engaging the healthcare consumer at this point in a much more direct way than the model that we're used to, which is a very passive model. The challenge is that passive model has led to this situation where, and we're better off than a lot of places, but where, because we don't see any of those costs or how it affects us or anything, costs have just skyrocketed and gotten out of control. What this piece does is it's saying there are a lot of places where we can do better on the cost front, and quite frankly, I think, on the actual providing healthcare front. But in exchange for that, what we are asking is we're asking you as the employer, the healthcare consumer, get engaged a little more with your healthcare and do this extra step of call and talk to the advocate and see what we can do to do it better. What we've tried to design this plan is that if you have no interest in that, if you're the employee who has no interest in doing any of that, that's fine. You can still do things the way you have always done, and you're going to be in a similar situation where you are now. But for the employees that decide that they want to do that, and as a whole, those of us who decide we want to engage and try to find those lower cost entities, we are getting the benefit of those savings that we can then pour back into our employees or to whoever.
But the employee that wants to, why does an employee select to save the money?
Well, I
What
think it's
to-
because
to
of
what's the benefit?
ourselves, right? Because let's say I'm living paycheck to paycheck, and I don't have any extra money, which is the case for tons of us that
Right.
work here. If you're living paycheck to paycheck, what I'm getting from this is if I advocate for myself, then if I take, and I don't, but let's say I take 15 medicines a month, if I'm not paying all those copays because I'm going with them and I'm getting stuff for zero, and I'm not paying the copay to my doctor because I've advocated for myself, and yes, I have to do some work, but I'm used to doing some work for myself to try to save myself money because I have to take care of me. No one else is taking care of me.
So I always use the analogy of in your life, in your daily life. I don't know how we got to this spot, but healthcare is the only thing the normal consumer doesn't shop around for. Think about your auto insurance renewal. Think about your homeowner's insurance renewal. We all have to shop for that. But when it comes to this one thing, we have left it to our employer, which has left it to the brokerage community, which has left it to the carriers. And so it's just, I get this question a lot, so I'm so used to it because people are, this is too good to be true. I'm like, well, fine, then don't do it. You don't have to do it. Use your ID card. That's the magic of this model is we're not asking you to take time out of your day to type us an essay about all your healthcare costs, right? Most people want to throw it to us and say, I just want to make it work. Just give it to me for free, and I just want it to work. And that's when the advocacy team comes in. I mean, heck, I have people calling, can you schedule my specialist appointment? I'm like, can I have your Outlook calendar? Like, sure. I mean, I'll schedule. But it's that type of service. It's a white glove service that, I mean, there aren't a lot of people that do this because it's really hard. Navigating through the healthcare system is very, very hard. We're just happen to be glutton for punishments. And so I hear what you're saying that, well, I don't want to have to work more. I don't want to have to do anything. I don't want to have to. Well, then don't. Take your ID card to your doctor and pay your copay. And it works the same way that it does now, right? Because you still have a network and you still have a copay.
Yeah, I mean, I'm just comparing the way, and I'm just taking the last 5 years of going to the doctor. I don't know how I would change that. I would go to my same doctor. I'm not going to change my family practitioner. I'm going to more than likely do what he says when he says that you need to go see this specialist. I want to go see that specialist. I don't want. I mean, he is the person of trust that I would have.
And the great thing is you can do that. But you don't have 30 different health conditions and 8 different specialists, right?
I know, but then I take 4 medications, and then, so how would I utilize anything to make my process cheaper than what I experienced today?
So with your ID card, your drugs are going to be $0 for generics right off the bat. So you went from paying for your drugs to 0 right off the bat with your ID card, right? Immediate win. Okay.
Well, I don't pay anything for my drugs today anyway. I go.
In your specific case, if your doctor, whoever the doctor is in the neighborhood network, we've saved you the copay right off the bat. Then,
And
even
what
though
if
you
he's
didn't
not?
change a thing,
That's mine.
even though you didn't change a thing, we've saved you that. If he's not in, then hey, we work with the advocacy
75 to
team.
30.
But the
Do
advocacy
what?
Say that again.
Like right now, specialist copay is 75. It goes to 30 immediately with your ID card. So we just saved you $45 every time you go visit a specialist.
And then the
It's
second
50
part
and
of that
75
is
right now is what it
from
says.
the plan, from the county as a whole's perspective,
No,
if
40 and 50.
your doctor is part of that network, they're probably getting a lower they've agreed to a lower payment rate than we're getting currently with Blue Cross Blue Shield. So not only have you saved yourself money, the county has saved itself money as well, and you haven't changed a thing. Now, if your doctor is not part of this network, you would call them. They would try to work out an agreement with your doctor, and if your doctor likes the rate that they're proposing and agrees to do it and take it, we're good. We're done. And in the space, some doctors are choosing they'll take a little bit less on the payment rate side in exchange for not hassle having to work through the big insurance.
Well, not having to
company.
deal with prior auths, pre-certs, filing claims, waiting 45 days to get paid. If we call them and say, hey, we know that you're getting $175 in Medicare, we'll give you $150 and we'll pay you before the member even comes in the door. That is time value of money for a physician that hates billing. It's real.
And so I feel like we've got two who wanted to say something for a while.
And I'm gonna put this kind of where Jeff is going. I have a family doctor right now that I have a physical next month. I have no idea. I mean, I just have a physical.
This is your
do
annual
do
preventative?
Do I call y'all and say, hey, I have a physical coming up?
That's going to be $0.
Because if not,
for you
I'm gonna pay a
anyways.
$50 copay.
No, preventative has to be 0. for
No,
you.
on that physical, we're allowed one
Okay.
per
Yeah.
year today.
So if I'm going to the doctor in a week or tomorrow, I got a sore throat, I'm gonna go to the doctor. I got a $50 copay. Is it better for me to call y'all before I go? That's
So-
gonna save my copay?
I don't think you'd have to call us. You would just need to know who the tier 1 providers are that would be 0.
What if
right?
what if my family doctor's
Yeah,
not?
that- well-
Today before they vote.
Yeah, we have a list of.
And I have never seen the list of that.
Okay, well, we showed it to the committee, so I can, yeah.
Then you've got the list, and you'll.
Oh, yeah,
you'll show
it's
us.
literally posted on our website, but
Okay.
I can email it out, yeah, for sure. So we would educate, when we come in, and this is the reason I've asked the committee, to be on site and talk to your employees because of these questions. Like, show me your phone. Let me show you where to find these providers. Here's how you save the providers. And it'll be Sonia and I pushing stuff out. Like, are we going to hang it in the break room? What are we going to do?
But
Like,
when you're saying providers, you're talking about doctors?
yes.
So,
But they're not just doctors anymore. We call them providers because they're MDs and DOs, right? Then there are mid-levels now that operate within the healthcare space, so that's nurse practitioners and physician's assistants. If you have surgery, you're not guaranteed to get an anesthesiologist. You could get a CRNA. So I just want to clarify for the court, it could be a provider of any caliber.
This could be a cardiovascular surgeon, this could be a cardiologist, this could be an endocrinologist, urologist.
Yeah.
But to Mickey's point, he's sick and he's gonna go see his doctor. But you would want him to actually shop that to see?
No, so when we sign you up and if y'all are gonna move to our plan, you're gonna have the list of $0 providers. You're gonna see, is my doctor on that $0 list? If it's not, then you just go and pay your copay as you normally did, right? Either they're on the $0 list or they're on the normal copay list. So we wouldn't expect him to call us if he's sick and going to a sick visit to the doctor he always goes to.
But
right?
as an advocate, though, you're saying that if my doctor's not on that,
We would wanna know, cause we would wanna call them and pull them in the
then
network.
yeah, I could call you and say, hey, to save me
100%.
that copay,
100%.
would y'all check on that?
Yes.
Well, see, that's, as just an everyday employee, saving money on your prescriptions and saving money on your copays is really where you're gonna save all your money.
Well, and
Because-
we're incentivizing you to take care of yourself, right?
Right.
If I'm thinking of the general labor population, I, from a clinical perspective, want to incentivize you to take care of these maintenance and routine visits and
Right.
medications, because I, in the long haul, as your employer, want to keep you well, because number one, you're gonna keep coming to work for me, and then as a county, I'm protecting that risk fund of benefits money, and overall, I'm gonna keep you employed longer, right? So you're contributing back into the place that you work, we're paying you, so then you're contributing within your family, and we're all benefiting here.
Yeah, and if you
One of
use
these
that-
days I'll get to talk.
Oh, sorry, go ahead.
Commissioner Beecham would like to say something.
I would have not said it that way. I was bringing my Beaumont roots out, about to go to Louisiana, by the way.
Okay,
That's
I've
all.
been trying to
Go
interrupt
ahead.
for like 20 minutes, so.
You
so-
have the talking stick.
Okay.
Okay.
Jeff, when we redid our plan a few years ago, when we added the higher deductible and reimbursable in that, one of our goals was to have our employees engaged in their own healthcare decisions. They can choose to do nothing and they pay right off of the plan. But if they choose to go and do the paperwork, they can get the reimbursable. It's pretty similar to this, what we're asking here. Now, beyond that, the advocacy model is almost what we put in place in the indigent health office, where our indigent health workers are looking at other means of providing those prescription drugs, et cetera. We've dropped those prescription drug costs by as much as 80% in the last 6-7 years. It's a model that works when you do a little legwork. So
Yeah.
I like the thought that we can go to an advocate to go fight those battles on our behalf.
Well, and I will tell you, it's not all sunshine, lollipops, and rainbows. This is a two-sided approach. It's not a them versus us. You know, we're going to come to you. The medical landscape is changing rapidly. We have all these new gene therapies that can solve muscular dystrophy. We don't stop. We don't live in 12-month cycles, and we're not just going to bring you reporting and a renewal. We're in it every single day with your people. We're finding conditions that you have. You have ticking time bombs that you didn't know were going to be a huge claim. That's why we do this. And again, the level of engagement, if you want an advocate, we're here.
Yeah.
We're not forcing you to come to us, right? That's not the model.
Lynn, did you, oh, sorry, Mark, did
No,
you
no,
have something?
no.
Okay, Lynn, did you have something?
I did have two quick questions. As I understand it, am I gonna need to change physicians, one that I've already built up a relationship with? Because they're not in your network, so I need to find one in your network?
So I'm going to keep going back to, we have a two-prong approach. So if we have
I
our,
understand your two-pronged approach.
so you don't have to move your doctor. No, number one, you don't have to move your doctor.
I'm just gonna end up paying a copay that I don't pay now.
So if you don't pay a copay, that means you've met your deductible for the year. So you had to pay a copay at the beginning
And
of the
same
year.
thing with my pharmacy.
Yeah,
'cause
exactly.
I'm tired of changing pharmacy.
Exactly. You don't, you don't have, we don't want to take a doctor away from anybody. Now, if you're using a doctor that you had to pay copays to before, and then you hit your deductible and you're covered at 100% for the year, that's a different story. And if that doctor wants to talk to us and we can pull them in our neighborhood network that you would not have that copay or deductible, we're happy to talk to them. And I will tell you, just locally, and expanding out even to the Dallas providers, we really don't have an issue. I mean, everybody knows our issue here locally, and we hope to resolve that eventually. But most of the time when you call the doctors here, they're like, wait, you'll pay us faster and we won't have to do pre-cert. We don't have to go through all this madness. And like clinics in North Texas, they've been a great partner with imaging, because you know, a lot of the times people just see the hospital as the easiest place to go get imaging, right? By imaging, I mean x-rays, CTs, MRIs, whatever all that stuff is. So we can give it for $0 clinics in North Texas. Most of the time, 90% of the time, the members can get in faster. You're supporting a local community clinic that needs the money. And so that's really the model, is we don't want to take a doctor away. It's just, will they participate in that tier 1 network is the question.
Because like now, mine's United Regional Physicians Group.
Yeah, so you'll pay your copay.
Right, but speaking of local, I mean, United Regional is local, and they're not profit hospitals.
Yeah.
That sure could fool me.
I'm gonna,
The United Regional question, I mean, it's a sort of the elephant in the room, but it's probably honestly a separate discussion than this one. From the plan for us to make decisions this week moving forward for 2026, we will assume that they will not be part of the tier 1 network. So those
yes,
discussions.
and I will say to the group, we have tried multiple times, and we have a lot of people leading the initiative, really trying to get to bridge the gap there. But at this time, you're correct.
Okay.
They will be going through the
Can I ask
network.
one more question?
Yeah.
Just not that this would ever happen to me, but if you fall and break your hip, and you have to go to, by ambulance to the hospital to United Regional, what am I going to pay?
$2,000.
And that's it?
That's your out-of-pocket
And,
balance.
okay. I just wanna
I'm gonna
make
get
sure.
hats
I
made.
thought that's what you meant,
$2,000.
but I just wanted to be
2,000.
clear.
Yes, ma'am. So what we did is we took this to our underwriters that underwrite our stop loss programs, and we explained, here's what we see going on in the population. Because what I did is I spent my whole weekend studying claims data from where everybody goes, what are they going for, and really kind of mapped out a process of how we think we can maximize savings. We know money will still be going to the hospital, but on 90% of the care we access, you'd be surprised, everybody thinks it goes to United Regional, it really doesn't. And so in the emergency situation, please do not collect $200 for pass and go, please go directly to the ER.
What about that, so same, like the hospital doctors, I don't think were in our network anyway, from what I had heard.
The physicians group?
Yeah,
No, they should be in
the
Blue Cross.
titanium?
Oh, the ER physicians.
Right, so.
This is the
But they're
traveling
still all
docs.
part, it's all in the $2,000.
Yes, on our, yes. So I'll just kind of expand on what she's saying. So there's a group of traveling physicians, and we have them in Tyler. We love when we see that NPI come up on our claims data. So they travel around and they work in ERs, but that physician group isn't necessarily contracted with United, Blue Cross, Cigna, or Aetna. So you tend to get sometimes out-of-network bills that they didn't know the site of service was actually in network, and that's what the No Surprises Act that we were talking about earlier with Karen, that's what it was supposed to alleviate. I'm going to just put caveat supposed, because it's kind of one of those, we're from the government, we're here to help. We're trying, so yeah. But the thing is like, you have an advocate. So if you go to United Regional, I mean, everybody's acting like you've never gotten a bill from a provider, right? If you get a bill from a provider and you send it to our team, we're going to take care of it. We're going to work hard and we're going to keep you posted. That's what we're good at. You don't need to worry about, I always use bringing a baby into the world, you know, why do we charge women for having babies? But you get a, anesthesiology bill, you get a provider bill. Sometimes you'll get a NICU bill. Sometimes you'll get an OB bill. And it's just overwhelming and they keep billing you. And that's what we're here for.
And so we actually send those bills to you?
If you want us to take care of them and research them for you, yes.
Like, because I have no clue typically how it works today, but I've never sent a bill to Blue Cross Blue Shield.
I'm not Blue Cross Blue Shield.
No, I've never sent one. I've received bills
'Cause they would
from
ignore
Titanium,
it.
bills from the hospital, bills from my doctor,
You
but I've
send
never
them to
sent them.
Higginbotham for your reimbursement every year, though.
I do, because Blue Cross and Blue Shield is the one that got notification, and then they in turn did or didn't pay.
Yeah, so
But I never sent one to Blue Cross Blue Shield because the
you're
hospital
fully insured
billed
right
me.
now with Blue Cross. So they're dictating all the terms of your health plan, right? Okay, I'm not an insurance company. I'm a third-party administrator that processes claims for a self-funded health plan, which would be the county. So the county is essentially their own insurance company with reinsurance. So if you send a bill to Blue Cross, they wouldn't even respond to you, right? Well, you're paying us to take care of you and your employees. So if you get a bill that looks like, why did I get a $500 bill when I've already met my deductible? That's usually the providers not coordinating benefits correctly with all the other providers that you're working with, right? So if you send it to us, we can probably resolve it in the same day, and you don't have to call multiple different people and try to get an answer. But if you want to handle it yourself, go ahead.
And I-
It's just part of our customer service.
And
I
that's,
don't-
that's one of the things that I probably like the best about this whole process is their advocacy team. They're advocates for us. If we're willing to let them do it, in my opinion, it looked like they were willing to do a lot more work for us that we don't
Currently have.
we don't currently do. And I'm not saying that
Well,
TAC
to-
doesn't have some ways
To
that
the
we can reach
credit,
out.
with the TAC model, I mean, everything's going to Blue Cross. I mean, if they could do it, they would do it, right? I truly believe that, but
And they have some things. I mean, when they
Yeah,
gave their presentation, we
100%.
asked them, they said, yeah, we'll do that for you. And I didn't even know that prior to that. Prior to talking to y'all, I didn't know that there were some
Well,
other options.
And my questions are because I'm pure ignorant about the whole situation, but if I'm the hospital and I'm not a provider to this group, to Cigna or to, and I'm Margaret and I go to the hospital and she whoops that Wichita County card out, I'd say, no ma'am, you might try Oklahoma City or go out to Kel West, but we don't accept what you're paying.
But the hospital here does. They participate, HealthSmart, Cigna, United Healthcare, Blue Cross, Aetna, Medicare, Medicaid.
Why are they then considered out of network?
They're not considered out of network. They're just not in our tier one, the neighborhood.
Yeah.
They're not out of network.
They're not, if that's the 2-tier, they're not in the neighborhood, that tier 1 network, but they are still in that outside second tier, the Cigna network.
Yeah.
Just because,
But those, I'm just gonna go back.
Yeah, go
Those are not stupid questions. These are great questions because this is the type of things that again, we're in this all day long. Like, we're here to answer your questions so that we can educate the population. You need to be educated to make this decision, and it's very important.
So most likely, you're not gonna have an out-of-network, you're either gonna be in tier one or in tier
Tier
two.
two.
They're gonna fall somewhere in one of those tiers. There's not really gonna per se be an
Mhm.
out of
I'll
network.
caveat just one time, those freestanding ERs that don't take any networks that aren't in your Blue Cross network, those are still technically, quote, out of network, but we negotiate with them and not worried about. There's only one in town.
Or
and
if you're
we're-
traveling and you might be out of state, out of country.
Cigna is
No.
national PPO.
But you might be anywhere.
but if you ended up in the situation where you're in that rare situation, but just because it's rare doesn't mean it doesn't happen,
Thank you.
where you've hit a provider that's not in the second tier network either. What happens then?
So I know this sounds simplifying healthcare. We call the provider and we say, hi, we are a self-funded health plan. We have money. Do you take money? And the provider literally says yes. And we say, okay, based on the CPT codes that you have submitted on this bill, here are the usual and customary that Blue Cross, United, Cigna, and Aetna, we've reimbursed you in this area. Here's an American Express, we'll pay you up front. Do you take money? Like,
So-
it's as easy as that.
And playing extreme devil's advocate here, but again, that's,
Yeah, no, it's a great question.
you can't get a hold of them. They say, no, I'm just going to bill your person. Come at
So
me,
you
bro.
know what happens?
See
The
what
bill, so
happens.
we have a hostile facility in Georgia, in Gainesville, Georgia, that has fallen out of most networks, and I have a large poultry production plant, about an hour and a half northeast, I'm a girl, northeast, of Atlanta, and the members send us the bill, and we pay the bill on behalf of the member. My chart is cleared, and it shows $0 balance.
Okay. Because, and that's where,
I don't foresee
to
that
Robin's
happening.
point earlier that I wanted to,
That's a plan paying.
right, I wanted to hone in on.
Not the member.
We could end up in this rare situation where that member is getting a
A
bill
bill.
for something beyond their $2,000.
Yes.
At that point, the plan then engages with y'all. Y'all talk to if y'all can't come to an agreement, y'all are probably going to have to do arbitration with them. But even in that situation where we're really out of the realm of possibility, then the plan could end up being on the hook for.
So the only situation that I could see anyone even go into arbitration over dollar value would be a double transplant, and you would go through a network for that. You would not go to a non-network hospital, because every hospital that does transplants is in the Cigna network, just to clarify. Yes, that's right. Because normally you're going to see, again, it's an ancillary bill from a traveling ER physician that's $1,100, and we're like, okay, $1,100, that's 250% of Medicare. Let's just pay it and make it go away. This isn't even worth talking about at this point, right? But the great thing is like, the member does have to send us a bill to clarify.
Right.
We don't know that it's sitting out there unless they
That's
send
what
it.
I was gonna ask.
And
Our members then need to, if they get something and they don't think it's right, they need to go to you and bring you the bill. Don't just pay
Keep
it.
in mind that if that is the case, and it is something that they call and they're able to work out something and pay the provider more. So standardly, let's say it's $100 office visit, and standardly you pay, what, $80 if it's a $100 bill? For example, so if the provider's like, I want my $100, and they contact them and it says, I'll take my $100, if the plan chooses to pay that $100, that's an exception. So that's what you need to be careful of. I just wanna throw that out there. That if that's the case, that's an exception every time that the county pays extra above and beyond, that's exceptions that are being made.
Well, and again, I mean, we're talking rare, and I know you're saying,
Right.
we're talking
I
rare
just-
Well, and we will
of
have
rare.
plan document language to address this, right? Our plan documents are created by FIA, the standard, and they know our business model, so so I don't have to go ask Blue Cross for an exception. That's the thing. I don't have to ask anybody for an exception.
No, but since we're self-funded, I'm assuming all exceptions are gonna have to come through the county for approval.
No.
That's part of, I don't know if it's SAGE, if it's the TPA's responsibility, but
it is.
we would have our plan documents set up so that we aren't getting in the middle of that. They
No,
would go-
these would be, let's see, if a blah, blah, oh, okay, let's use a transplant, because we've got somebody that's kind of upset about us at a transplant. Well, he won't stop drinking to get on the transplant list. So can't be mad at us that the hospital, Vanderbilt, is telling him he can't get on the transplant list, right? So he goes to the grievance committee. Well, there's no grievance with the health plan. It's a grievance with the hospital system, right? And so those type of things, these, again, very rare,
Yeah.
but we have so much plan document language on level 1 goes here, level 2 goes to clinical, level 3, if it has to go to the county, it has to be above $50,000 or something, whatever it is. So there's, and I would love to look at the plan document language with you, because you'll see, because again, we don't have to go to Blue Cross, or we don't have to engage the county.
No, I
on that.
understand. I'm just
Yeah.
saying that if you standardly pay $80 for this service for anyone else, but you're gonna pay the $100 because that's what the doctor wants.
So
where
I
the
will
plan
say,
doesn't have the exception to be able to pay extra, I guess. is
In
my
Wichita
point.
Falls, where predominantly all your people are accessing care, we have contracts set up with these people that
Right.
say
Yeah.
you're going to be paid 150 of Medicare. So
Right.
the only providers here that I would see having an issue with like that is that freestanding ER that doesn't participate in any networks. But we will educate. If you go here and you get a bill, please send us the bill.
Yeah,
So.
and again, with all the whole discussions around the rarest of the rare,
Yeah.
but I think
But it's
Robin,
real, and it
well,
comes up,
and I think
so-
Robin's trying to get to a point of making sure that we want our employees to have full expectation heading in of, if this is what they said that they were gonna do with the benefit plan, that's what the actual on the ground
Yeah.
truth is.
Mm-hmm.
No one benefits if that's not the case, and so I think we're just trying to make sure that
Yeah.
was,
I'm not. So this is about our, 200th plan launch. We do it in our sleep, and I would not come in here on public record telling you I could do something if I hadn't repeatedly done it over and over again. My reputation is very important to me, and I like my insurance license and my TPA license, which was very hard to get. So I think this is a great discussion, because we are talking about rare circumstances that will come up. I said it wasn't sunshine, lollipops, and rainbows, and I mean that. And I'm going to come to y'all with constant ideas, and you're like, God, what is this crazy lady bringing us this time? But it works. It works 100% of the time. Never seen it not work. And the financial side of it to me is a no-brainer once we get to that, if we are ready to segue. Are there any other questions on benefits, in, out of network? And we can talk about this multiple times if y'all want. We'll be on site. If y'all decide to work with us, we're going to be here and post up. I'll have a ton of my employees here for Q&A. We only ask that you let us eat once a day. So this discussion does not, I think this is really good. And I think this is why, we are grateful for this opportunity, and we want the employees to understand that we work for y'all. I mean, we don't work for an insurance company. We're yours. You pay us to advocate on your behalf.
I did have a question though. I get the 1-tier and the 2-tier and all
Mhm.
that stuff, but is there like a maximum for the employee that they are allowed to have, under insurance, like heaven forbid somebody.
Oh, like a lifetime
Lifetime
maximum?
benefit?
Yes,
No.
like a lifetime
oh my gosh, I'm aging myself, but when I got into the industry, there were lifetime maximums. No, Barack Obama with the Affordable Care Act, some good came out of that long time ago. January 1st, 2014, I'll never forget that day. The lifetime maximums went away. You cannot have a maximum on an employer-sponsored health plan like this. Now, if you had one of those indemnity plans, like the individual plans you go out and get from United Advisors, I think, has one. United Healthcare has like a minimal coverage. Those have maximums that have to be listed, but these plans cannot have a lifetime maximum at all, or an annual maximum.
So if you were to get a really bad diagnosis of cancer or something, and the employee wants to go to MD Anderson,
Yeah.
that would be covered. I mean, obviously.
Yeah, that's the reason as the county, so as to the employee side, again, $2,000.
Yeah.
Cigna
And
Network.
$2,000 is cheap. I mean,
Relatively speaking, if you're getting $500,000 a year in oncology treatment. But that's the reason we're about to go into the financials. So my job is, number one, to protect the employees and make sure you can access the health care you need that's affordable and high quality. Number two, I also have to make sure giving you that health care will not bankrupt your county, which is a very important thing. And we run under budget with all of our counties every year. I wish Upshur County was listening right now. So that is a great segue into the belly button deductible that I talk about, the specific deductible. If you, I don't want to curse you at all, but if you had a rare disease that maybe you wanted to go up to Johns Hopkins or Mayo Clinic. So that's why we have that big fluffy network, and you can go there. The specific deductible says the county will never pay more than that $150,000 because the reinsurance carrier is gonna, that's called advanced spec funding, too much lingo, but they're never gonna pay that. So once you hit that 150, the stop loss carrier is gonna pick up the bill, and there's no maximum to what they reimburse, right? So you can't have those maximums
So
at
there's
all.
no like last minute zinger kind of thing. Oh, y'all are on money. So.
No, I will say, just like your fully insured plan right now, you know, if you have bad claims for a year, I think that you know, you've had to have where you start at 25% and then you get down to 10 and this year's 0 because TAC wants to keep your business, which is respectful, right? They want to keep your business. You're a very important customer to them. And so to me, you're not going to hurt the county in 12-month cycles. This is a 3 to 5 year plan, right? The rule is you have 4 really good years, then you have a bad year, right? But you have those reinsurance protections that you'll never pay over that maximum amount. And that's the reason we only work with A-rated stop loss carriers. Like, I'm not going to go out and work with a C-rated carrier that's not going to pay my claims. So we work directly with Berkshire Hathaway, who is our underwriter, and that's Warren Buffett, and I would take his advice on anything pretty much. So those are really good questions because it's really important.
Yeah, I think, you know, because with the Blue Cross, you know, we've had Blue Cross Blue Shield forever, and it's just comfortable because we know, and this is something new that we don't really.
Fun fact, my mom was a Blue Cross Blue Shield of Texas employee since I was 11 years old. Imagine how those conversations go.
Oh, I can imagine.
What are our cards gonna look like? Are they gonna have like a?
I have a
Cigna?
picture.
Okay.
Oh, please.
Cards.
Oh, yeah,
Well, I'm
we,
serious, that some doctors
they're
will look straight at a
pink,
card
they're
and it's
big
gonna say
pink
nothing,
everywhere.
right?
Actually, you know what?
So can I afford to put my family on
I mean,
it?
it's
Yeah,
gonna say
so
PPO,
that's where-
We're gonna have a Cigna.
Well, and that's
So,
what she's about
so
to
I
do.
will say that's a great point. So we really handle new ID cards proactively.
See,
So
it's a good question.
it is.
It's
So
a great question.
when you all make the decision, there's this thing that activates within our team, and we have a pretty large team that we're kind of like the SWAT force that comes in. So we proactively, I know all the providers that y'all go to. So we have this process where we will call them, hey, do you want us to drop the card by? Because we will put the card, Wichita County logo, Sage logo, here's the picture of the card, you accept this. This is the county's moving to this. And we like stay in front of it before activation date, which is January 1st, so that there aren't those. Now, are you gonna have random new providers, somebody goes to Dallas and they'll have to call and verify benefits? Yes, that's gonna happen. But the 90% of the providers out here, because we're already communicating with them all day long, they'll have, and let's be honest, y'all live in a place like Tyler, like I live. Everybody knows everybody and everybody knows what's going on. So they're gonna be ready for a new ID card from a county employee. But we really do proactively reach out and make sure that they know what the card looks like, make it all fluffy. But yeah, so I'm sorry, your system does not communicate with Mac, so I'm having to use Hannah's computer. But it's literally would just have the Sage logo, the county logo, Cigna would be here, and the normal PBM here. So it looks exactly like your card now. Just take off the Blue Cross logo.
Gotcha.
So
It
you
doesn't say PPO.
you still no. Well,
It's not
I can write
PPO.
PPO on there if you want me to. Yeah.
I'm just-
Yeah, I mean, everybody here knows that Cigna, the national network, there isn't a Cigna HMO here locally. So nobody would,
Gotcha.
yeah.
And on the back, there will be the advocacy information, so if you happen to think, oh, I need to call an advocate for something, you can pull the ID card out and turn it over, and it'll route you to their number.
And we also get, that number is normally for, members, but we get providers calling all day long, hey, how do we get in that tier 1 thingy that you're talking about? You know, cause think about it, the providers here what's their goal? They want more patients. And so that's kind of how that goes. But good question. I should have started with the ID card. Everybody wants to see the magical ID card, which is, I have to say something. It is kind of interesting if you were like an alien looking down on us. Like we have this magical ID card that we bring out. It's like an unlimited debit card. Like it's wild, right? How did we get here? But I digress. Okay, let's go into financials. And if y'all behind me think of other questions, please interrupt if we didn't talk about something. Okay, so we're gonna go, we went to the fixed cost, so let's go down. I did hear something in the commissioner's court last week that I wanted to clarify because I did put a portion on the presentation that has a part of this, and Matt, this might be a question for you. The HRA budget right now that y'all are setting aside, you're only spending about what, 200,000?
That's right.
200,000. So, but there's a number budgeted that's bigger than that, and so I put that in. That's not. I don't want to say it's not real money to me, but I did put a bottom line factoring that in. So I've got basically as is now. If we add the HRA budget in there, then we look really good. Let me go to the claims fund. So these are called aggregate factors. So when we talked earlier about fixed costs and aggregate costs, so variable costs are your aggregate factors. So this set of numbers, the 617 that has the EO, e-spouse, e-child, those are the worst case scenario claim funding factors that my underwriter has come up with to doomsday that worst case scenario. Everybody hits spec and we just have a really bad year. And that's how we come up with your max liability. So those numbers have been underwritten based on your claims data that we have through August of 2025. Now, when you look at this additional laser liability, this actually, we've already got a solution for this. This is a member that is going to UT Southwestern with a J code for a specific drug. Running through Blue Cross is like $26,000, $27,000 a pop. We have a direct contract with UT Southwestern that Mark Cuban has been working on for us, and we do a lot of cash pay, really fun stuff with them up front. So not worried about that at all. I think I can get that lifted. It still doesn't make the overall exposure.
Because I know that this was a point of contention for the committee, and I don't think that we want to recommend anything that has a laser. So.
Exactly. So, but even if you factor the laser and the max liability,
What does that even mean?
Oh, sorry. So this is where an underwriter comes in and says, okay, we are clearing everybody to meet the $150,000 specific deductible for the whole county, except this one person that has a very high cost drug, but it's not a high cost drug on our program, right? It's a high cost drug on the normal carrier programs. And so what I did, mind you, I got firm rates within 2 business days for y'all, so I'm still working on it behind the scenes. These are firm. The laser that they brought out was $250,000 a year, so it's $100,000 over your individual spec limit. But we already know where the member's going and the drug they're getting. So I went to the carrier and said, hey, here's my game plan, here's my rate. Can you just lift that laser? Even factoring that laser in, you're still lower than where you are now. And we'll talk about that in a minute. So a laser is like, all I want to think about is Austin Powers, like lasers. It's basically a carve out where you have a specific deductible for a high cost claimant.
One person treated, one claimant treated differently.
So a laser point, in other words.
Pretty much. I hate that word. I wish we could call it something different. But it's real in our world, and I have to factor that in. It did start out at $400,000 and they moved it down to $250,000, so I'm hoping they'll just lift it all together. But again, even factoring that into your max exposure, you're still better off than you are now. So this is just my head in a spreadsheet, so we're going to go down to, okay, nope, go all the way down. More? Yeah, okay. So this is the question I have. These 2 bottom numbers, 6.614718, 5112693. So this is all in if you take the HRA money and put it over into the budget. To me, I know it's real money to the county, but that's not really apples to apples to me because it's not fair. So I did that on the bottom just so you could see what that looked like because I heard Commissioner's Court last time. But our recommendation at the max funding is you keep your contributions as they are. We don't want to back off because that is max funding. We're going to max fund for the first full year and we're going to build up that reserve and we're not going to let you touch it. It's just my recommendation. I have had groups that are saving $1 million 6 months in, and we want to pull out. I'm like, no, remember we need a healthy claims fund because every year is not going to be a sunshine, lollipops, and rainbow year. So again, up here with the $150,000 deductible is what we're recommending. And with your laser in, you're at 5.112693 current, and it goes 5138. So it's $25,000 difference, which that's a J code on the health plan. I'm not worried about that with that laser lifted. So again, same deductions for the employees. We're not charging the employees. We're not recommending you increase deductions. We're not recommending you increase the county contributions at all, right? So that's the main point, is it's not costing the county more. It's not costing the employee more.
And per the discussion that the committee had that came up, this keeps the current 5-tier premium structure.
Yes.
So it does allow for employees who just have spouse coverage or child.
So think about the same deductions you had for open enrollment last year. It'll be the same deductions and the same tiers. We're not touching those at all.
Yep.
And
It's gonna. Oh, go ahead.
What happens to the deductible plan that we have today then, that is $3,000, but we buy it down to $700?
Yes, so-
What happens?
The HRA would go away under this plan because we just aren't spending that money. We're removing that because the whole point of that was to get people's out-of-pocket costs down when the county had to make the switch to the higher deductible level. Since what we're proposing is, especially if you are actively involved in your health care, for most employees it's going to mean less money. We'd be doing away with the HRA completely.
So, I just thought of something. So if you guys are you actually, because you're county, you have to budget that money.
We do. It's in the 26 budget.
Okay, but you're only spending a couple $100,000 of it.
That's correct.
So technically, you could work around that and back off your max to carry. Okay, so that's your
Yeah.
Sorry, my Excel brain is coming into play. So the news here is that, again, county employees will not pay more. I'm just going to keep saying that out of your paychecks because I think it takes 7 times. The same tiers: employee only, employee spouse, employee child, employee plus 1 child, employee plus family. Same deductions that you have right now coming out of your paycheck.
Yep.
Is everybody
Okay,
nodding?
so just to be clear, the employees, which is 97% of the insurance users in this county, pay $0 for health insurance. There are people that have a family plan that would pay, but they're like less than 10.
So there are 37 employee child, 38 employee child plus 1, 7 employee spouse, and 1 employee family.
We will keep the same format where those folks, their child, their family member,
Will
whatever.
come out.
No, they would be able to still be covered under our health plan.
But they would
They're still going to pay that
pay
portion.
the
They're paying the
difference.
same thing they're
Okay.
paying
Yeah,
right
same
now.
thing.
Yeah,
they're paying now.
so if you think about your benefit guide communications that you do for open enrollment, as to the employee, those that are coming out of their paycheck is just no changes at all. And this is a lot of change already, so we really didn't even want to, I didn't want to lower it, I just don't want to recommend that because there's a lot of change going on, and I think keeping as much as we can stable right now throughout the change, because I know it is going to be a lot for the
Now,
employees.
down this road, if we see significant savings and we build
100%.
up that fund,
Yeah.
the court could choose at that point to reinvest some of that money and
Yeah,
say,
because
offer a richer
the
benefit
goal is to
package.
make it, where it is affordable to add a spouse. Because let's be honest, on a county salary, adding your spouse or your child it's a lot right
Yeah.
now. And over time, you see, usually year 2, year 3, you can start playing with those tiers. But right now, I am a super conservative underwriting brain, and I just don't think that's a good idea right now. I wish I could make that recommendation. It's just not here right now. So. Any other questions on financials? I did put the lower specific deductibles up here, but I'm a big don't be overinsured type of person as to paying an insurance company fixed cost premiums that you don't need. So for an example, $100,000 specific deductible would usually be about a 250 life group in my book, in our block of business. You go up to our 10,000 life groups, they have $1 million specific deductibles, because the higher your deductible is, the lower your premium is. And looking at your claims data and your large claimants, what I did is I did a what if scenario. If we had 150,000 last year, how many people would be over, how many people would be under, and what would that underwriting look like? And 150,000, I actually went up to 200, but it didn't make any sense. I didn't feel comfortable with that. So that's my recommendation, is that $150,000 specific deductible. I think that y'all are leaning towards using the Cigna network to have that bigger fancy logo. It is a little bit more expensive. It is factored in here. It's about $94,000 for the rental network, whereas a Health Smart is about $35,000. But your discounts as to mark the cost of care up to hit a discount is gonna be higher with that Cigna network. So, I know that was a lot, sorry. I just had to caveat that.
But, so your forecast for looking at where we've been over the last 5 years typically with the ups and downs, and we've got somewhat younger over the last couple of years. What are you forecasting our insurance costs to be?
Yeah, so I am not a fool and I will not sit here and act like I know everything. So just to clarify, but I did study your claims data and I have been looking at the patterns of where your people go. You do have an emergency room problem that we can immediately resolve with some education. I think that you have an emergency room here that is probably manipulating your plan design that you don't see. So I think emergency room, we can take that down utilization a lot, which would mean about $500,000 back to the county's budget. And the member gets better high quality care. I think the problem is we've heard this in this area before we started really building a primary care model. It's very hard to get into primary care provider at certain facilities. I'll just say that. So when you don't have a primary care provider and you have a member that can't afford their maintenance medications to keep their diabetes under control, then that ER is just the easiest place for them to go after hours to use it as a primary care facility. So we really work on that. The drug spend, immediately your drugs are gonna go down about 35 to 40%. Just because your specialty drugs, your infusions, I repriced all of them.
But drugs
And so-
cost us what today under Blue Cross Blue Shield?
Hold please. So from January to August. Ooh, there's a lot of pressure. $636,000, and that's 8 months of data. So if we,
$1 million a year.
Yeah.
yeah, about right at $1 million. Now I do have to caveat. One thing that I did not factor in here is pharmacy rebates, but you will be retaining all of those. It's impossible. It's about $200,000. I'll just say that, but.
Under
Yeah.
promise and over deliver.
That's right, exactly. So I wasn't even going to go there. We can have a work session on that later. But you all, again, I said something to begin this, is I do not retain anything other than that PEPM fee you pay me. Any rebates that come through the plan are passed directly back to the county.
So, I mean, she said 35 to 40% off prescription costs. It's $350,000, $400,000.
And you can provide it to the members for $0 and waive their copay because they're letting us find those sources and not just going and paying, the Walmart, CVS of the world, the inflated cost that goes through a PBM. So pharmacy benefit
in the
manager.
proposals you may have seen these, but when the committee was really looking at these proposals, the anticipated claim spend based on historical data was anywhere between about 3.9 million all the way up to 5.2, depending on who was offering the proposal. So that gives you a range to work with. We know what the max is going to be based on the plan design. And I mean, realistically, I don't think it's shooting too high to say $500,000 of savings below that we would see. I think it could be higher.
The secret is going to be teaching the employees to utilize this system.
Because right now our claims
Period.
numbers are where they are, with no incentive for anybody to try to find lower cost care or to
Well,
negotiate.
and I will say, I will remember y'all's names eventually. I'm so sorry. It's just kind of, so apologies that I did not know your first name. But you said something that training the employees to use our programs is very important. But I will say, even if you do have your members that just use their ID card and go to pharmacies, because we are using a 100% pass-through pharmacy benefit manager, all you're doing is paying a per script fee to them. They're not marking the cost of the drug up to hit a rebate, right? So it's kind of gets you out of that marking a drug up to $1,200 to hit a $250 rebate game. So if they don't come to us and they still pay their copays, the county is still going to see savings with them using their ID card to get drugs. So I just wanted to add that it is just a philosophical change of moving from a traditional PBM model to a fully pass-through.
So we have to go through the local pharmacy?
No, you can go to
At that, it
yeah,
would be just
yeah.
period.
Yeah. And we'll do a whole work session on pharmaceutical shenanigans. I teach that class really well because there's a lot to talk about.
Is that a good segue into talking about the rollout timeline?
Sure, yeah. Does anybody have any other questions on fund financial? Happy to send everybody my spreadsheets. Okay, so Elaine that runs the Wichita County business, she really is kind of my co-consultant when I'm running around doing other projects. She works on our groups here. She put this together. She called Sonia because I heard a lot of, we have to do open enrollment in October, and we can do open enrollment in October. I will say with what we do, I think it's a little different than, I don't know, everybody. So when I'm building your health plan, so like I just pulled up and I logged into my system, my claims processing system, and we can build your health plan based on your plan benefits within like a day. It's literally my team sitting on, and we're building in all the health plan items. And by that I mean specialist visit, how's a drug gonna be covered? And it's real time live because we're built on Salesforce, right? And so we don't have to go send a benefit grid to Blue Cross, and then Blue Cross sends it to another department, and then they have to go to a review. We're controlling all of it within our internal system that we have built, right? So let's just kind of take everything we know about open enrollment and let's just put it aside. So we're proposing, and we ran it by Sonia, and Sonia, you chime in here if I'm not speaking correctly, is if y'all make the decision on Friday the 3rd, the 3rd, we will immediately get to work the next week. So we want to talk about if the county wants to do town halls with the employees in October, just to ask questions, a forum like this, the spouses can come, you know, whatever y'all want to do, we will make ourselves available for y'all to do that a couple of days in October. So our software that we like to use for open enrollment is called Employee Navigator. It's a lot of people use it as no secret sauce. We can get that up and running within a day because again, we control that. So the outward face into the employees is, do you want us to come on site and help them enroll? You know, I think traditionally, Sonia, correct me if I'm wrong, y'all have done paper. Mm-hmm. And so this will be new to the employees. We don't have to do the enrollment system, but I'll tell you, like, it's 2025. And so a lot of paper just isn't, it's a lot of manual work. And so I would recommend, because we can come, if I can teach a whole poultry production group of people how to do this, I can help with the county. And my people can sit there with their computers, walk them through what their benefits are, ask any questions about their drugs. And so that would be, I think we decided open enrollment would be, I think that the 11/6, the very green stuff up there, 11/6, 7, and then 10th through the 13th. And we would be here, again, we would post up in a room, however y'all do it traditionally, and we would have our advocacy team here, the account manager that leads the Wichita County accounts. And then once we close open enrollment, what happens from there, and I'm not sure how in the past y'all have done it, I think everything gets submitted to TAC, but I know that there will be a Higginbotham file with all the ancillary products. And so if we need to help y'all merge that together to get one payroll deduction file to upload into your system, that's what we normally do. So we'll do it, we peer review and we do an audit of it, and then you, in whatever template you need to upload into your system. I'm hoping that y'all aren't manually keying this in.
Rachel, Dean usually with Colonial comes in and does the ancillary, he'll be doing the ancillary.
But are y'all keying payroll deductions into your system as a county staff? Does your system have a template that we could use to upload? Yeah? Okay, perfect.
But they do.
That's a big deal because I just immediately saved them 2 days of work.
But Dean does use the Navigator, Employee Navigator.
Got it.
Also,
Perfect. Because getting the file in the format that you need, because think about it, we're Tableau Salesforce based. So I can slice and dice this eligibility file or a payroll file, however y'all need it to ingest in your system. Because I can build it however.
You don't do it, but this is Matt's giddy face. He's giddy right now.
Oh. Well, Matt, you'll love Salesforce and Tableau. So that's really, once we cut open enrollment off, like from there, think about it. We're going to take your eligibility file, which was all your names, social security numbers, dependents. We're gonna immediately upload into our system. This is automated. This is not manual. This uploads into our system. We assign a member ID. From there, the ID cards go to print. This is a 3-day process. So if we're done by 11/14, my goal, I'm under promising and over delivering, would be to have ID cards in everybody's hands by December 15th. Now, we will probably deliver them out here so that snail mail and UPS we don't have a lot of blame. I know how that goes. But the problem is, On the other side, if we get the ID cards in everybody's hands too fast, guess what they're gonna start doing? Using their new ID cards. And then they're gonna get mad, she's like, I can't fill my drug. I'm like, well, because you're using the wrong ID card. So we really need to time that and keep communicating that your new ID card is to be used January 1st. So that whole process of getting ID cards printed, delivered, I am not concerned about the timeline at all because I don't have to rely on an outside party to do any of those steps. I print the ID cards in-house. I brought that in-house because the vendors were all terrible. So I'm not too concerned about timeline. It's more of how do we equip your team that they're not feeling like they're doing more work or pressured under time constraints, because we don't want to suggest a change if y'all feel like we're moving too fast. But on my side, again, we do this all the time. I'm not worried about it at all. So that is Elaine. I would have written 2 sentences, by the way.
That's good.
So, any questions on deadlines, how we do open enrollment? I mean, we're kind of an open book here, so.
So let me play devil's advocate. We have a lot of.
I can see this is how this is gonna
a lot of dependency on you.
Yeah.
And we're gonna rely a lot on you, and a month from now we call and no one answers the phone. How do you show us, or how do you prove to us your credit worthiness and your financial stability as a company?
Yeah, I'll tell you, I will send you my audited financials. I have 0 debt, I have 0 shareholders, I have 0 private equity involved in my life. I get to work with who I want to work with. I'm very blessed. My husband told me when I moved from Houston, Texas to Tyler, Texas, that I didn't have to work. So that's a lot of credibility there. I do this because I like it. I'm good at it. I have a huge team that are as passionate as I am. And you don't know this, but I'm over here texting a CEO of an insurance group that I'm working while I'm talking to you, and there's air traffic control between multiple different parties that work on my team, taking care of people.
Rachel,
so,
how many covered lives do y'all have?
oh gosh. At this point, 211,000, but we've got a 23,000 life group onboarding January 1 in upstate New York. It's a school consortium. Mark Cuban, I would say by January 1st will be about 240,000.
Who are your 3 biggest clients in the state of Texas?
My poultry production client, which is John Souls Foods. They're in 3 different states, but their hub is in Tyler, Texas. San Antonio School District is a large client of mine. Spa Glass Construction, they build all the HEB stores and all the medical facilities. Mark Cuban's a big one.
Your oldest one is how many years?
10 years old since I started my company. Yeah, I couldn't take any of my old clients because Gallagher sued me so many times. So I had to start over new in 2016 when I started. But we don't have any client turnover. The only way we lose clients is if we have somebody, like we had Houston Physicians Hospital as a client we custom built a plan for, but they came, Memorial Hermann bought them, and we can't really compete with Memorial Hermann. So.
And I know that the committee knows this, but in case the other commissioners that weren't by that want to call, who are your in-town folks you cover and other counties that you cover in Texas?
Has anybody heard of James Frank? Yeah, you can call James. Actually, he called me on my way here. He doesn't know I'm here, so he might now. So James Frank, and then Calco is here. They're really small, so it's kind of hard to compare Calco to the county. But James, we've had Sharp Iron, Transland, and Delta T, which have doubled in size since we took them over. I think, 21. Wow, I cannot believe it's been that long. So we're on our 4th cycle with them. And it has been a learning experience with them because we went in, we spoiled their employees. Yeah, so we were methodical on planning this plan design with everything we've learned. It's been a fun ride, so yeah.
And other Texas counties?
Other Texas counties, Upshur County is a long-term, they're about 300 people where y'all are about 450, so I think that a lot of people here think they're really small. It's funny, Gilmer's actually booming out there. I have had them since 2017. They have run under budget every year. We've had them. I think they have $3 million surplus right now. Their county judge, Judge Tefteller, if anybody knows him, he'd be happy to talk to you. Do we have any other? I think that's it. No, so Wichita County, Smith County just called us. That's a long story. I'll talk to you about that later.
Okay. But I'm sure.
Yeah.
Robin.
Yeah. What is your average of incoming phone calls to customer service? How many customer service advocates do you have also?
Well, hold on, and I'll tell you how many have come in today. I would say a lot of our stuff is through the app now, and it's not on a phone. So I wouldn't be giving you an accurate number, but as to phone calls, so we can go into the ticketing system and I can show you how many advocacy tickets we have. So Hannah can do that, and then I can pull the phone calls up. Okay, so like today, what is today? The 30th? I have had 204 calls as of 2:49 p.m. and we have 13 people on the phones.
What's your average call time?
22 seconds. Because most of the time they're just calling about claim status and they have access to a portal that they can check their claims.
Okay, so how much advocacy do you do? Is that through your customer service line?
No, our customer service line is just for providers. Now members can call in and they get a soft transfer.
I'm
to Hannah.
talking about member calls then.
So
not-
Hannah
not
will
provider
log into
calls.
Fresh Desk. But our turnaround time on an advocacy response, I would say is,
Within an hour.
within an
Less.
hour or less. I mean, we don't have an issue with that at all. Cause most of them, it's, think about, most of them are drug issues, like, that sounds terrible, but I was prescribed a new drug, how do I get it for free? So it's us going and grabbing a copay card, and we have access to the claims adjudication system. So again, like, we're not having to tell the member to hold on, we've gotta go to somebody else to fix the problem, we're fixing it right then.
Yeah, that's
So.
what I'm curious about.
But we can run you some reporting.
Average talk time
Mhm.
and, how many phone calls? you
You'd
do
be
with the
surprised,
advocacy?
not a lot of people call. It's a lot of texting, because nobody likes to be on the phone anymore.
And that's fine, same
Yeah.
thing, just inquiries in general.
Yeah.
What is your average inquiry?
Easy to
per
run
day?
that.
Yes, so we've received 27 advocacy inquiries today,
Okay,
and the average resolution time, meaning start to finish, is an hour and 50 minutes. So that's any
Okay.
time from like what's come in and when it's completely resolved and members moved on.
and that's, I'm assuming that's your system that you track all of this in from the opening, from an open inquiry to a closed inquiry?
That's correct, yes
Okay.
ma'am.
Okay.
And we can actually, like, when we took on Mark Cuban and his employees, we actually send him call summaries every day of who called in, and then we send him ticketing, because he wants to see, like, okay, do I need to go direct contract with this facility or whatever? And so we can even send y'all that data, just so you know what you should be communicating with your employees
Right.
about. But
Do you, also in your system, I'm assuming you track what the call was about?
Yes, we
What is
do.
your highest call that you get in?
Pharmacy.
drugs.
Okay,
Pharmacy is gonna be the highest one, and then subsequently it's gonna be procedures, so that's anything from an inpatient procedure to an outpatient surgery.
okay,
And it trickles down from there all the way down to as granular as like, I need my ID card because I forgot it at my mother's
Yeah.
house.
yeah. Okay, yeah, I think numbers on that would be good.
Sure, absolutely.
Yeah, and you can pull, we can filter by client or like tag, if you just wanna see how many people called about drugs that day, I mean, you can filter through. I built all of this software so that honestly, I never had a client ask me, what's going on in our health plan. I don't like being blindsided by a CEO when I'm having dinner with my husband, which happens in Tyler. And so I have all this metrics so I can sit down and study it while the girls are, the worker bees are behind the scenes and I can monitor it. So you had a really good question. I'm not going away. Unfortunately, if you call anybody in our client book, I'm kind of all up in your business a lot. And I do enjoy bringing you numbers and educating, because this is a lot of money and it's super important. And I'm an open book.
This
I'm
is-
almost too
this is
transparent.
This is super important. This is as important to our employees as their pay is.
100%. Well, it's your number 2 line item, I guarantee you. I mean, 1 or 2.
And that's why we wanna make the best decision possible.
Yeah, I agree.
Sure.
I do have a couple other questions.
Yes, ma'am.
What is your, do you do subrogation?
We do not do subrogation. Our general counsel handles it, Matt Schaefer.
Okay,
So he handles all that, and that's
Okay.
internal.
okay.
Yeah.
And then as far as, do you just follow the standard coordination of benefits
Mhm.
rules that
Mhm.
most insurance companies?
Yep.
Okay.
Yep. Usually birthday, and then if y'all have any Medicare primary that are on any y'all really don't have a lot of retirees, so we won't have an issue on that. Because what we've learned out here is a lot of people don't subscribe to the COBA Medicare, the HHS or CMS platform, and so it's a manual process, but it is with most companies anyway, so.
Okay.
Yeah.
Okay.
And who does your medical review? You have your own internal, or do you?
Yeah,
farm that out?
so we have internal until it gets to a certain point, and then healthcare strategies is our, like, say we need a pediatric cardiologist and they need a peer-to-peer, we use healthcare strategies because they have specialists that talk to the same specialist. So like, y'all have heard all the stories like, oh, somebody had an OB-GYN talking to a spinal surgeon in a peer-to-peer. We don't do that. We outsource to healthcare strategies, and they are very sophisticated and amazing.
Are your
So-
medical policies available for, like us to look at?
Well, they're gonna be in your plan document. So yeah, we every single pre-cert, everything is gonna be in your plan document.
And for all your medical policies that you
Oh, yeah.
follow for covered or not?
Oh,
That's
yeah.
Correct.
Yeah.
Do y'all
That would be
ever,
good to look at too.
excuse me, do y'all ever like deny the coverage or?
100%. Somebody wants to go get their, a facial reconstruction because they have stress. Like, we get people all the time wanting plastic surgery on our plan. Oh, yeah. Oh,
I
yeah.
mean, like a legit-
Somebody actually wanted to go do psilocybin mushrooms in Mexico, and they wanted the health plan to cover it. So, yeah. Not joking. This stuff comes up. And when I say it's not sunshine, lollipops, and rainbows, there are procedures that we have to follow a plan document.
But like if my doctor says, hey, she needs like a heart stent or something.
So we like to
you know,
cover those. Yes,
things
we
like
want to cover
that.
ours. That's a necessary procedure.
Well, you know,
Yeah.
you say that.
I'll take it, yes. So there are medically necessary procedures, right? A heart stent would fall under that medical necessary category.
Okay.
And then there are something that I would call, elective
Mhm,
procedures. So varicose veins,
mhm,
nobody likes them, right? But they are not medically necessary
mhm,
to have dissolved.
mhm.
So that would be one that would fall, like, yes, your doctor can recommend it, you're
Mhm.
welcome to have it pre-auth, you're welcome to submit an appeal for it, but if it is not falling into that medical necessary category,
Mhm.
listed under your plan document that you'll have access to, then it would be a non-covered procedure. Now, if you still want help with trying to price that and find the lowest cost, advocacy's happy to help you with that because you will be coming out of your own pocket for that procedure. But a cardiac stent, we certainly want you to get that taken care
Or,
of.
you know, like sometimes, a cardiologist will be like, okay, we're gonna do an echocardiogram every 3 years or
Sure.
whatever.
Preventative.
You know, is there like a time limit on that, like if you have one, or if you just think, hey, you know, I go to my cardiologist and I'm like, I'm feeling a little flutter here every now and again and stuff, and it's like, well, you know, it's not within the 3 years, but since you've talked about the flutter, we'll go ahead and talk, you know, we'll go
Yep.
ahead and have
So that would fall into a separate category that's called the diagnostic bucket, right?
Mhm.
Because you have symptoms that now
Mhm.
are being considered for any diagnostic element, and that would fall into a separate bucket of procedures, and absolutely that would fall under a medical necessary coverage portion.
Alright, cause you know, I've just heard of people having
Sure.
issues with like, you know, my doctor told me I needed it and I had it done, and then they'll, you know, Blue Cross Blue Shield says, hey, you know, we don't wanna pay for
I
it.
ain't spending money on that.
And then they had to go through the whole rigmarole trying to get it paid, and it's just a lot of work, but.
Absolutely, understand. And something that's important to note for everyone is that the goal of how this plan works, and works very well from both a financial perspective, and then you mentioned, sir, that taking care of your employees and their health benefits is #1 priority here, as congruent as their payroll, right? By allowing you all to consume healthcare at a considerable level so that you're then incentivized to take care of yourselves is the #1 goal here. Because what we don't want to happen is that flutter to be missed, and now you're in the ICU and someone's having to say goodbye to you because we didn't, not we, but you know, if we're collectively, it wasn't considered to be a problem at that point. We want to avoid situations like that.
Okay. I was just curious, like how, you know.
Sure, what are the tier levels of coverage and things like that? Absolutely. And you'll have summary of benefit and coverage guides that we'll look at during your open enrollment. You guys will have access to your own plan document. It's a transparent process that you'll know going into it where you stand.
And I will tell you, I'll one example of what's come up lately. So we, under the ACA preventative guideline, a CT calcium scoring test is not under the 100% preventative. And so a lot of times a cardiologist will want you to get a calcium score done, and it doesn't fall into preventative, so you're having to pay a copay or deductible, whatever. Well, we consider that preventative, so we put it on our preventative list just because it's a $75 test. Yeah.
Cause I paid $75.
That's what I'm saying. And I'm like, why don't we just include it under preventative? It has found so many underlying issues lately. And so we actually have providers that our members go in and they're like, they just automatically say, oh, that's not going to be covered under your health plan. They don't verify benefits or anything.
Oh, yeah.
But because every other health plan out there doesn't cover it under the preventative, so we have to call, hi, why did you tell them to pay for this? We cover it under preventative. And they're like, wow, I wish my health plan would cover that. And it's like, and it's $75, but like in the long run, if we could catch something with a $75 test that the plan covered as a preventative, and you're not a $500,000 patient in the cardiac ICU, I mean, that's the way that we think of things, so.
So, since you brought that up, that is something that y'all recommend that we would put into our plan document because it's not a
Yeah,
covered
100%. That's in our standard plan documents under preventative.
And that's all things that we will go over
Mm-hmm.
what's normal, okay,
Yeah.
Yes, ma'am.
okay.
Yeah, so we will put your benefits into our standard plan document, and then we always have I don't know, 5 or 6 buckets that we like to review. Like, you know, is this your preventative list you agreed to? Here's the ACA list. Here's how we like to expand it. Here's how we handle pre-certs for image, you know, all the normal stuff. I do not do that. My ADHD cannot sit there with that, but Karen will run through that whole benefit thread with you.
Okay.
I have one other question that we talked about before,
Sure,
specifically that Robin had brought up
Okay.
about skin tags.
sure.
Yeah.
And you said before that was just a covered deal, or it could be a covered deal. How
Yeah.
did you word it? And I don't, in this one, is it or is it not?
So this is what we're gonna go through on your plan document. I actually don't think that skin tags, I mean, I would prefer that you remove them because it's so cheap. And it, to me, for people, we cover those under our plan document because it's, I mean, how much is skin tag removal?
$12.
It's literally nothing. And so to me, like, why wouldn't you just put that on your dermatology offices at copay? That's what we do, but we're gonna bring that to the plan document review and say, here are our recommendations, because,
Because no other insurance is really anything like that.
well, no other insurance wants to cover a CT calcium score either, but it's
My
like,
doctor at Clinic North Texas classified that as surgery.
And it is, it's a surgery code, it
I
is.
mean,
It is
she
a surgery
froze it
code.
off.
Yeah, it's a surgery
Yeah.
code.
She just froze it off, it took 2 seconds, and then it cost me, I had to pay $280.
that's my point. And when we could pay under the copay, under our contract, I don't know, to me, it's like these little tiny wins that don't cost anything in the long run. Like, why would we not do that? Like, why don't we focus on the $150,000 infusion going through UT Southwestern and not a $12 tag?
Right.
I don't know.
And that was some of my questions, and that's what I wanted to show, that our employees, that we are wanting to put stuff in there that will help you on everyday type medical stuff.
Yeah.
More people
Okay,
deal
I'll
with the
give you this
everyday
example.
medical than they
So,
do with the big stuff.
Out here, CPAPs, having to pay for CPAP machines. Okay, so like we use a DME company that's a wholesale DME company, kind of like Mark Cuban's Cost Plus Drug Company. It's a DME company that we use. It's Cost Plus. They have an 8% profit margin, and so if you think about where DME, like CPAPs, crutches, wheelchair, if that's going through a network or a vendor that the networks want you to use, you can just mark that up about 1,000%. And so we tell people, okay, if you get prescribed a CPAP machine, come to us. It's $0 to you, and our CPAP machines are how much? I don't even know.
Like, depending on what you get, about $220.
Whereas, you know, run it through a network, it's $1,000. So it's stuff like that, that like, and men, sorry, I have a husband, if they have to go pay for a CPAP machine and actually keep up with the supplies and have to go pay for the supplies and this, we've just learned they're not going to keep up with it. And then they're going to have all kinds of infections. So it's like, why wouldn't we give them the supplies, check in with them? How's your CPAP going? Are we sleeping? I mean, to that, it's a huge benefit because you're not having to pay that deductible and all those supply fees. So that's kind of another little, I don't know, tiny win that we have that's very cheap overall.
And that CPAP gets delivered to your house like Amazon. So you can receive Amazon packages, we can send you your CPAP at home, same way. If you don't want to receive it at home, we can mail it to your work.
Yeah.
I've done both.
What is your claim throughput percentage?
Are we talking about networks in general, or you want to talk about Wichita Falls? Because that's a very broad question. Because if I go to Baylor, UT Southwestern, they don't do I have to scrub their claims all day long, and you know why. I have to scrub those.
Yes.
Here locally, because we have most of the contracts on a Medicare Plus model, our system is programmed with the codes, with the Medicare rate. And so if we get something that's not built in as a health plan item on that contract, it's going to kick it back to a processor where they're going to look at it manually. So I'd say here, 90% of the claims are clean. I mean, the only ones we'd have to really dig into clinical is like an ER visit for a cardiac stay, an air ambulance, you know, I mean, stuff that's really an outline. NICU stay. NICU stay. How do you bill 48 hours and 24 hours? I haven't figured that one out yet. If y'all can get 48 hours and 24, let me know. But that's the stuff you find on hospital bills. It's like, how are you billing for 2 days and 1 day? And she's talking about a clean claim submission. That's a big deal. So thank you for that question.
And then do you do, I'm assuming, do you do bundling?
So it again depends on, am I beholden to a Baylor contract, or am I working with clinics in North Texas or a surgery center? So if we had NICU labs, we would be not allowing unbundling of those labs, and we would say, okay, no, this is under your NICU per diem rate. But if we have clinics in North Texas running preventative labs on a panel, I mean, that's pretty standard. So I'm not going to have to unbundle that, right? So kind of, I know I keep saying it kind of depends on the facility. But
And it does. I don't
if
disagree with
healthcare were consistent, my life would be a lot
Yeah,
easier.
I don't disagree with that.
Yeah. But good questions.
So would something like IVF still be considered a subnorm?
So, yeah.
Something like what? I'm sorry.
IVF.
Look, I'm like, yeah. I have mixed emotions on that, and so as the plan right now, because we're kind of mirroring the plan document language, it's not covered as it is now. So we cover the testing, of course, but to me, that's not enough. So yeah. But just so you know, New York State covers it, because we just had to change our whole plan documents for that, up to women age 60. So
Whoa. Okay.
yeah, I have so many words. Okay, so any other questions as to, what, and y'all might not even, Judge, y'all might not even want to do town halls and then open enrollment. It's really up to you. We just want you to know that we can be here when you need us to be here. It might be overkill, but I kind of like to overdo it, and if nobody shows up to come talk to us, we're just going to be sitting here working anyways. So.
And something Elaine and I talked about the other day was, she said they had a video, I guess, that you guys could
A
send
recording?
out. Yes,
Mhm,
recording. And that maybe we might opt into sending that out to the employees ahead of time and allow
That's a good
them
idea.
to, allow them to kind of get the introduction and all, and then have the town halls, as you call them, so that people with questions, because not everybody's going to have questions. Some people are going to grasp it, but for those that do have questions, can come into the town hall meetings that we're going to set up so that they can ask those questions.
They might give them some ideas on what questions they need to ask.
Well,
Watching
yeah.
that video before.
Yeah, watching that video prior to, yeah.
And this is
And knowing
beneficial for your folks that have spouses on the plan. They'll
Or
need to
children.
go home and children, they'll need to go home and share that with their family so they can have open discussions and bring those questions collectively when we're on site.
Or for men that need their wives to translate everything for them.
Yes,
Yeah.
ma'am.
But not that
I'm
that's
feeling
ever
attacked
happened. You feel attacked.
That's twice. as
Hey,
much
you know what?
as
I don't put gas in my car, so I'll take that trade-off all day long if I don't have to pump gas. So.
Did we get the list of providers yet, or did I miss that?
Do you
Oh,
want me
yeah,
to?
the list of providers.
Can you? I'll send you this.
Well, y'all did,
Oh, you know
I'm
where
just
it is.
curious, so the county's funding all this, and they are fee managing?
Yes, so we are paying, there's really two buckets of money. Essentially, we're paying them to manage, and them meaning EBC is getting a per employee per month fixed amount to serve as our broker. But then Sage, which is their third-party administrator, is also getting a fixed amount to administrate the whole plan, and all of those different things that she talked about earlier, little pieces of what we're paying them a set amount to manage our plan for us. The rest of the other big bucket and the rest of that money is just the money we set aside to pay out claims.
So right now, y'all are spending about $415,000 a month, sending that to TAC and Blue Cross, right, for your fully insured product. So it's going to be the same thing. We're just breaking it up into little buckets, and we will. Our first financial review, I'll have a pie chart of where all our money is going, so we can look at what our percentages are. And the bulk of your money, 85%, should be going to take care of your people with medical and pharmacy needs. We just have that fixed cost in there for the people that are the hamster wheel back here, and then the reinsurance that's going to cover any of those high cost claimants.
Okay.
Yeah. Oh, you got it? Oh,
Now.
I don't know what.
We lost them.
I am putting it back.
Oh, okay.
I have personal health information
You're
I have
good.
to
Oh, yeah.
protect, so I can't. I have to disconnect and reconnect, so I'm
That's funny.
taking care of folks.
So, and I will say here, predominantly, the only people we're not working with or contracted with that aren't in that tier 0 are going to be United Regional and United Regional, the physicians group. I mean, that's really, I don't know.
Is it neighborhood network?
They're the ones that are going to be out of the neighborhood.
Right.
Yeah, but
I didn't,
So you have practice, okay, specialty, provider last name, which is where most of them go by, unless you're seeing a mid-level, then usually you'll call them by their first name.
Is there anything on there that shouldn't be broadcast to the world?
no, these are just provider names.
Okay.
It's
Just
their
provider
MPIs. You can
names.
Google it and find your doctor's MPI.
Yep, that's correct.
Yeah, so we have built this, and it's I can tell you there's not we don't have access issues.
Is there somewhere we can see that? where
Yeah, we
I
can email
see
it to
that?
y'all, and you can
Yeah, you can.
distribute
Cause I
that.
can't see anything.
Well, and one
I
thing
know,
that we
it's
will
fine.
do is if we'll send this out, and if you guys know of providers that we don't know about,
Yeah, but it'd be nice if we're gonna do it to be
Send
able to
it
talk
to-
to our provider ahead of time.
Well, and send it to
say-
us, and we can go ahead and reach out to him ahead of the effective
Right.
date.
So
But I will say, we've talked to pretty much everybody in town, so,
Can we
but
send
we're.
that out countywide?
Yeah, we can.
I'd like to send that out countywide.
Yeah.
All
Yeah,
of
let
our
us,
employees.
we're gonna clean it up and take the MPI, not that the MPIs are anything privileged, but, oh, we already have it on our website. Okay, it's already listed on our website, so
Yeah, and-
I'll send you that one.
If you'll send me that, I can get that out,
Perfect.
definitely before Friday, just so that
Perfect.
folks
That's great.
have a chance to see it.
And then I'll send the link to Cigna providers as well, so that if anybody has a specialist in the Metroplex, they just want peace of mind, that
Okay.
we have done, I did look at all the providers that are going through Blue Cross right now and overlaid,
Easier?
and there's not
Yes.
somebody, the only person that would be out of network is that freestanding ER here that's not in blue anyways,
Right.
so.
Is that big enough for everyone?
Yes.
Okay, I'm just gonna slowly go down.
Okay, who else looking for their doctor right now?
I saw my heart doctor, we're good to go.
I got the G's on there, we're good.
I
Yeah.
know.
Family practice is not though.
Is,
Family
is, it's right there.
medicine?
Family
Family
Practice Associates.
Associates.
Yep.
Yeah, ours is not in.
Preston's not on there.
No, not that I'm aware of. I don't
Who's
think he
that?
is.
What's the name?
Dr. Preston?
Preston.
Oh,
Oh, it's Family Practice Associates.
actually, we found
Oh.
out, we looked it up, cause you were the one that asked about that.
Okay,
So he bills under his MPI, which is Family Practice Associates.
Okay.
so all of them? are-
But we'll make sure,
Okay.
we just might not have somebody, we might not have anybody using him at this moment. So we just will reach out and say, you know, hey, you are gonna be billing under Family Practice Associates, you know, obviously.
Sure.
Yeah,
Is that,
cause we have that clinic's filing claims.
It should be tapped.
I was gonna say, is that not tapped?
There's a typo, excuse me, tapped.
Well,
Let me know if I need to stop anyone.
So if there's OBs at the clinics in North Texas, are they?
that would probably be.
A clinic's North
on there?
Texas,
'Cause
yeah.
It doesn't show it there, that's why. I'm
Yeah,
just-
there,
They're
there's a
gonna
whole.
fall under,
Under
they
just
just, clinics of North Texas, and we list them under a separate bucket. Yes, ma'am.
Yeah, it looks like we have one member at Sharp Iron.
Pulmonologist,
Family
I'll
Practice
keep going.
Associates is billing for them.
Just holler at me.
I'm gonna get down to work.
It's the TIN of the clinic, so we'll find out if they're gonna, usually they're just billing under the TIN, like the MPI of the clinic, not, so I don't see individual providers because they're, the claim form, let me make sure.
Just talk to the advocacy team more.
Evidently,
Grant Ron Thomas is on
they do
there.
pretty good about getting people on
Yes.
that list.
She's not on there.
We use Tacoma rheumatology as well, so we put them under the Tacoma physicians bucket if you see a Tacoma provider, so Dr. Erin Schreiner.
Oh, yes, Dr. Lowe now, she got married.
Okay, so.
We
she-
love Dr. Schreiner. We love her.
She falls
Okay,
falls
good,
under
good,
that
good.
Tacoma,
She's-
correct,
Is there a local endocrinologist on that?
yes. I have one.
Oh, please.
I didn't see that yet.
Yeah, 'cause I think all of them are with the United Regional Clinic. Case.
Yeah, you're good. And this is what, you know, when we're coming at town hall or open enrollment, whatever it is, you know, if somebody has a provider that isn't on this list, I mean, we have plenty of time to reach out and try, and all they can tell us is no.
Yeah.
So,
And if they don't, it's just gonna be the copay.
The
that we
normal
normally
copay,
would
that's right.
pay, So it's not a big deal.
Yeah.
It's not, it doesn't fall under the $2,000.
Yeah, I mean, you're not
And the
in.
copay's gonna be cheaper than what we've been paying anyway,
Yeah.
so you still have to save money out of it.
This is our company for 40,000.
It's gonna drop to 30.
Yeah.
There's more than one good company in the Sleep Network.
Yes. I don't think it's gonna be a big deal.
Okay.
Well, and I will tell you, you know, it's not like they're not gonna be able to find somebody to help them. We have a whole team of people that are gonna be working on this, so.
Well, I know I'm gonna be the one that everybody's in my office is gonna go to. I have to be very educated on this, cause everybody's gonna be asking.
All right,
I'll be like, go to.
I know that you're still looking up stuff then, but it's 3:15. I'll let everybody get away. Any other questions for the good of the body? Okay. Commissioners Court takes this up on Friday. If commissioners, if y'all have specific questions, I can get you EDC's contact info. Or if any employees has questions, you can reach out to Sonia, who'll be happy to pass them along. Any of the committee members will be happy to pass those along or get you connected to them directly. What am I missing? Anything else?
And I'd reiterate that, if there's any employees that have specific questions that they really need answered prior to Friday, or something that you think is monumental that we need to know about prior to that, definitely send it to her and let her send it and get an answer. We'd like to know the right answer before Friday and be able to make the right decisions.
Yeah, and Judge, feel free to send my cell phone. My cell phone number is
Okay.
it's not a hidden.
I wasn't going to assume that, but
Yeah. I'll just route it to James's phone.
there you go. All right, anything else? Okay, well, it is 3:14 and meeting is adjourned. Thank you, everybody.